We are going to start by Krishna. Dr. Neha, you can start.
Hello.
Yeah,
Hello.
yeah, doctor, you
Uh,
can start.
okay, Gaurav, I'm starting. So, good afternoon, everyone. Hope all of you have enjoyed a good meal. And now we'll begin with our academic session on e-posters and free papers in Hall B. We'll first start with e-poster presentation and then we'll move on to our free paper presentation. So, first, let me welcome to our respected judges. For Ma'am Dr. Anandita Sinha Babu. She is currently the head of Department of Pathology in College of Medicine and JNM Hospital. Dr. Shukanta Chakravarti. He is a histocytopathologist, invasive diagnostic procedures expert, and NABL lead assessor. Dr. Sonia Gon. She is the head of Department of Pathology in ESI, PGI, MSR. Dr. Shubhalakshmi Mukhopadhyay. She is the head of Pathology Department in Dr. B.C. Roy Postgraduate Institute of Pediatric Sciences. Dr. Barnik Chaudhary, His areas of interest are dermatopathology, pediatric pathology, neuropathology, lung pathology, and autopsy pathology. Dr. Tarak Barnik, he is currently an assistant professor in Malda Medical College. So before I begin the e-poster session, let me first explain you the basic rules for presentation. All presenters should have good broadband connection. Presenters are requested to keep their camera off and mic muted when not speaking. Total duration for speaking is 7 minutes. Sorry, for presentation is 7 minutes. There will be reminder at 4th minute, and I will say that 1 minute is left. And last 2 minutes will be there for questioning. Hope everyone is clear. So let's begin. Okay. Now I would request our first presenter, Dr. Amit Kumar Pramanik, to get ready with his presentation. Dr. Amit Kumar Pramanik is from Eye Care Institute of Medical Sciences and Research. His topic is dual primary tumors and enigma. So Amit, please start.
Am I audible?
Yeah, you are audible. You please proceed.
I'm sharing my screen. I'm here saying showing host disabled participant screen sharing.
Yeah. Gauravda, please look into the matter.
But you are audible.
Yes, so my screen is now. I hope it is visible.
Yeah, we can see it. Yeah.
Okay. Now I'm starting my presentation. Good afternoon, everybody. I am presenting the case report, dual primary tumors and enigma. The existence of two malignancies having different histopathologies at two anatomically distinct sites suggests the diagnosis of dual primary malignancies. Presence of more than one primary cancer in a single patient was first reported in 1879 by Bill Roth. Since then, frequencies have been increasing and reported within 2 to 17%. Most of the multiple primary cancers are double primaries, ranging from 3 to 5%. The two cancers may be synchronous when detected simultaneously or within 2 months as per the Surveillance Epidemiology and End Result Program SEER definition, or metachronous when they appear more than 2 months apart. Although incidence of gallbladder carcinoma is about 0.5% of all malignancies, and appendiceal neuroendocrine tumor is the fifth most common gastrointestinal neuroendocrine tumor, but their synchronous presence in a single patient is rarely reported, which prompted to report this case. A 45-year lady suffering from flatulence, mild weight loss, occasional pain in right hypochondrium and right iliac fossa for about 1.5 years. Basic clinical and hematological examinations revealed microcytic hypochromic anemia and raised EHR only. In USG, chronic calculus cholecystitis with fundal and segmental adenomyomatosis, figure 1, and CECT findings corroborated USG findings with respect of gallbladder and reported a thickened and fibrotic appendix, figure 2 and 3. The clinical diagnosis was chronic cholecystitis with cholelithiasis and recurrent appendicitis. On Ghosh examination, gallbladder measuring 6 into 3 into 2 centimeter with a thick whitish area of 3 into 2.5 into 2 centimeter in the body and fundus, figure 4. The appendix is 5 centimeter with long with swollen tip, 2.5 centimeter on its greatest dimension, wall thickened, lumen obliterated, figure 5. On microscopy, gallbladder showed two patterns. Pattern 1 showed dimorphic population of cells with marked anisocytosis, vesicular to pycnotic nuclei, and prominent nucleoli arranged in vague acinar and alveolar pattern. The other cell type showed clear cell morphology. This leads to think of a poorly differentiated adenocarcinoma, grade 3, figure 6. Pattern 2 showed round cells arranged in solid nests with stipple chromatin and inconspicuous nucleoli having brisk mitosis more than 20 per hyperfield. This pattern resembled that of a well-differentiated neuroendocrine tumor, grade 3, figure 7. Hence, keeping the two entities in mind, histopathological diagnosis of mixed neuroendocrine, non-neuroendocrine neoplasia, median of gallbladder was thought. In section of appendix showed monotonous round cells arranged in nests and cords, having round nuclei and finely stippled chromatin, obliterating lumen and inverts up to subserosal fat, figure 8 and 9. Mitotic rate was 25 per 10 hyperfield. So the diagnosis was Grade 3 well-differentiated neuroendocrine tumor of appendix. For confirmation, ISC was done. In ISC, gallbladder tumor was diffusely immune reactive for CK20, CK7, figure 10, with focal positivity for CDX2 and INSM1, and negative for CK20, figure 11, or synaptophysin, figure 12. The ISC results removed the histomorphological doubt of menin in gallbladder, and it also indicated tumor of primary origin. Therefore, the diagnosis was poorly differentiated adenocarcinoma of gallbladder. Appendiceal tumor was diffusely positive for synaptophysin, figure 13, and INSM1. Ki67 proliferative index was more than 20%, figure 14. So the diagnosis was well-differentiated neuroendocrine tumor of appendix, grade 3. Therefore, the final diagnosis was dual primary malignancies with poorly differentiated adenocarcinoma of gallbladder.
Dr. Amit, you have 1 minute left.
And well-differentiated neuroendocrine tumor of appendix. As per Warren and Gates criteria, in multiple primary malignancies, each tumor should present a definite picture of malignancy, should be histologically distinct, and possibility of metastasis of each other should be excluded. And all the criteria were fulfilled in this case. As per the classification of North American Association of Central Cancer Registries, in AACCR, this case was synchronous dual primaries as both tumors were revealed simultaneously. In spite of the histological confusion of menin in gallbladder, double primary malignancies was a more reasonable diagnosis as it proved by ISC and corroborates with NAACCR definition as well. In conclusion, this case highlights two facts: that histomorphological resemblance can mislead the diagnosis, which can be eliminated by use of ISC and demand more regular practice. Secondly, lesions present anatomically away from the primary malignancy may not always be metastatic, as presence of another synchronous primary malignancy is always possible. It also mentionable that though there was no suggestion for any malignant lesion in this particular patient, either clinically or radiologically, but revealed by histopathology and proved by ISC. The patient is under surveillance in this institution. Thank you.
Time is up. Yeah, thank you.
Thank you. Very well presented. Now, can I ask a few questions? First of all, why not mixed neuroendocrine adenocarcinoma of gallbladder per se? Why not it is a mixed neuroendocrine and adeno of GB?
Sir, it was not menin, as because gallbladder carcinoma, the tumor cells in gallbladder should have at least 30%. The two entity must be 30% of the entire tumor, as per the definition of menin. There should be a neuroendocrine component and non-neuroendocrine component. But in this case, which was preliminarily thought that of a neuroendocrine cells, but it was negative by synaptophysin, and for that reason, it is not a menin.
So you are considering the neuroendocrine part of the gallbladder as metastasis from appendix?
No, sir. It is not a metastatic. As it is a poorly differentiated adenocarcinoma, so it resembles that it is of a neuroendocrine component.
But it was not. But this 30% is for purely mixed tumors. But any kind of combinations can be there.
Yes,
a little
sir.
bit of neuroendocrine in a adeno, a little bit of adeno in a neuroendocrine.
Yes, sir.
The entire spectrum is possible or not?
Sir, may be possible, but as per the definition of menin, it should be at least 30%. The two components should be at least 30%.
For mixed, it is at least 30%. So you are establishing that your histological diagnosis of neuroendocrine component in GB was wrong as proved by IHC. Is
Yes,
it
sir.
so?
Yes, sir.
Okay. And can you tell what is the prognostic difference in this case of being two dual primary and not metastasis from one to another?
Sir, in case of metastasis, the prognosis will be more worse than the dual primaries.
Okay.
Okay. So Amit, was nice presentation. Now, nowadays, you know that detection of dual primary tumors are more as compared to previous era.
Yes, ma'am. Yes, ma'am.
Can you tell me what are the factors responsible for this dual
Yes, ma'am.
primary tumors?
Due to the more survival rate of the primary cancer patients. They are and due to the newer methodologies of detecting cancers and more the detection rate.
That means if a patient, if you are getting dual primary tumor, then what are the factors responsible? What are the things you should look out?
Sorry, madam.
Suppose you are getting dual primary tumor in a patient.
Yes.
So my question is, what is the factor responsible for dual primary? Do you know that? What are the factors responsible? Etiological factors?
Etiological factors.
Yes.
There's some genetical predisposition, and there, if it is a primary tumor, and after the treatment of chemotherapy or radiotherapy, the gene was it is more possibility to develop the second primary because of the instability of the genes.
Okay. Like, for example? Haven't you heard of any Lee-Fraumeni syndrome or Cowden syndrome?
Yes, ma'am.
You know why there is dual primary? So in every dual primary tumors, the patient must be genetically susceptible to develop multiple malignancies at a time, right?
Yes.
So do you know any syndromes or which dual primary tumors are very common? Yours is not very common, but some dual primaries are there which are very common. If you are getting one, you should search for the other. No? Okay.
Shall we move on to next presentation?
Yes.
Okay,
Okay,
Neha,
sir. Thank
one thing.
Yes, ma'am.
Where we were giving the marks?
Ma'am, I think Gaurav has supplied you the ma'am this Excel sheet.
Okay.
Yes, ma'am.
Let me
Okay. Okay. Oh, so thank you, judges, and thank you, Amit, Dr. Amit. So moving on to our next presentation is by Dr. Meghadeepa Mandal. She is final year PGT of RG Medical College. Her topic is three unusual cases of intestinal metastasis and its clinical pathological correlation. Dr. Meghadeepa Mandal, are you ready? Please share your screen. Yeah, she's there.
Am I audible?
Yeah, you are audible. You please start with your presentation.
Okay, I'm sharing the screen.
Okay.
Is it visible?
Yeah, this is visible? You please start.
Okay. So my topic is three unusual cases of intestinal metastasis and its clinico-pathological correlation. So let's directly move on to the first case. It was a 50-year-old male patient who attended the emergency with clinical presentation of acute abdomen. Exploratory laparoscopy was done, ileal perforation was noted, segmental ileal resection was done. We received the specimen in our lab and we did the extensive grossing from the areas around the perforation. There was congestion and exudation, but no gross ulceroproliferative growth. So on the histopathologic section, we found that there were typical tumor cells, as we can see in figure 1 and figure 2, that was infiltrating into the submucosa, but the overlying mucosa was absolutely normal. The individual tumor cells were markedly pleomorphic with vesicular chromatin, prominent nucleoli, increased mitosis, and focal areas of necrosis. So we were thinking of some undifferentiated malignant neoplasm. When we called upon the patient party, we looked into the patient's history, and it was revealed that the patient had suffered from melanoma 10 years back. So that gave the first clue. We went for the ISP, and S100 was available in our department, and it came out to be diffusely positive in the tumor cells. So both the histomorphology of prominent nucleoli, very much atypia, positive melanoma history, S100 positivity, ultimately helped in the final diagnosis of intestinal metastasis in a known case of melanoma. Now, as for the second scenario, it was a 60-year-old female patient who attended the outdoor patient department with anemia and OBT positive Colonoscopy showed a constrictive growth in sigmoid colon, and segmental sigmoid colon resection was done. We received the specimen and we saw constriction in the sigmoid colon, and we gave multiple sections. We saw that there was some atypical cells with a squamoid characteristic, as we can see in figure 4, present in the muscularis propria in the serosa. That in this case also, the mucosa as well as the submucosa was absolutely normal without any dysplasia, without any atypia. And similar atypical cell infiltration was also seen in the periserosal fatty deposits. So this again made us think of some kind of metastasis maybe. So we again looked back into the patient's history, and it was revealed that the patient had received treatment for cervical squamous cell carcinoma 5 years back. So both the squamoid morphology with an absolutely normal mucosa and a positive history of squamous cell carcinoma helped in arriving at the diagnosis of colonic metastasis of cervical squamous cell carcinoma. As per the third case, it was a 65-year-old female patient who attended the surgical emergency with symptoms of intestinal obstruction. Imaging showed that there was constriction in the small bowel. Segmental ileal resection was done, and constrictive area was seen with multiple serosal nodules and mesenteric deposits. Now, we gave sections from all the suspicious areas, and it was seen that there were some typical cell clusters of cells which was mainly present in the serosa as well as involving the mesentery, as we can see in figure 6 and figure 7, and they had a papillaroid architecture with solid areas as well, and the nuclei were bizarre pleomorphic, increased mitosis, focal areas of necrosis, and very high grade morphology. So we asked for the history, and it was we came to know that the patient had bilateral high grade serous carcinoma of the ovary 6 years back. So the papillary architecture, along with, again, in this case, a normal mucosa, positive history, helped in arriving at the diagnosis of high-grade serous carcinoma of ovary metastasizing to small intestine. So now we looked into our literature. We can see that there are few cases where the melanoma has metastasized in the GI with manifestations in the first 5 years. But in our case, the time lapse between the initial diagnosis of melanoma to the GI manifestation was 10 years. There are also few cases of cervical metastasis to the gastrointestinal tract with GI manifestations like our case. And as for the third case of ovarian metastasis,
Meghadeepa, 1 minute is left.
We have seen that it has been discussed that the mode of metastasis may be through the intraperitoneal seeding or hematogenous spread. So the common dilemma in all the three cases was that they were masquerading a primary colonic neoplasm, which was the main problem. So when we delved details into the clinical history of the patient, along with the suitable ancillary investigation like S100 helped us in the first phase, we ultimately came to the diagnosis that they are not primary colonic neoplasms, rather they are intestinal metastasis from a previous known malignant neoplasm. So with a broad outlook, proper history, and with a clear suspicion, if we look into these cases, a proper clinical pathological correlation may help in arriving at the proper diagnosis. Thank you.
So Meghadeepa,
Yes, ma'am.
yours was a nice presentation.
Thank you, ma'am.
Can you tell me in the third case particularly, where it
Yes,
was metastasis from ovary?
Yes,
So it was adenocarcinoma from histomorphology. So why
Yes.
didn't you think it of primary?
Ma'am, because the mucosa,
Metastasis? Yes.
yes, ma'am. Ma'am, when we gave through and through sections of the suspicious areas, the mucosa of the colonic mucosa and the submucosa did not have any atypia. The deposits were limited only to the serosa and the mesenteric fat. There was no dysplasia, atypia, or any pre-malignant neoplastic process in the colon. As well as there was typical papillaroid architecture with a true papilla in some areas. Some areas also had a diffuse sheet-like arrangement. So therefore, we thought that it is not a primary colonic melanoma.
And in the second case?
Yes, ma'am.
Sorry, in the first case?
Ma'am, in the first case also, ma'am, as you can see in figure 1, the upper, there is a little bit
The
of the
first
mucosa
case,
that is...
whether you thought of the metastasis first, or your thinking was this is a primary tumor, but upon delving into the history, you could identify that this is secondary.
Yes, ma'am. In the first case, our was like, it can be some large cell lymphomas. We were thinking it can be some large cell lymphomas or maybe some epithelioid yeast, high-grade morphology. we were thinking on that line. But then the patient gave, there was this prominent nucleoli which made us think that it may be a dealing, maybe some with melanoma. And then the patient gave the definitive history that the patient had melanoma 10 years back and 800 was available. So
Okay. So the actually second case and third case, you were thinking of it to be metastasis. Then you
Yes.
took the history and got it. But for
Yes.
the first case, you were thinking it to be primary, and from the history only you could. Okay, fine.
Yes, Meghadipa, very nice presentation.
thank you, sir.
You have in all the three cases, you have highlighted history as a very important tool of searching the primary or recognizing it as a metastasis. It is very
Yes, sir.
true. Can you tell some other factors which are helpful for identifying a primary apart from history?
That it is the primary colonic neoplasm.
No, when you search any primary or you suspect primary of any site, what are the tools what will help you?
Sir, if the site of tumor is on multiple locations, then we will think of that it is coming from other locations. Then if there are multiple sites of involvement, bilateral involvement, this will help us that maybe it is not the primary pathology of that location, but rather coming from some other source.
Can you tell a few common IHC markers which can differentiate between abdominal adenocarcinomas are a very broad spectrum. Many primary sites are there. Can you tell a few common IHC markers which can
So
differentiate?
CK7, CK20, we can do CK7, CK20. The different combinations of positivity and negativity can help us. CEA is maybe positive in abdominal and intestinal malignancies, like that.
CA is for any adenocarcinoma. And
Adenocarcinoma.
for confirming the intestinal primary or GI primary, any the marker which indicates GI origin, intestinal origin.
CDH1.
CDH2. Okay. And can it be a recurrence of CS cervix with contiguous spread to the rectum?
Yes, sir. It may
In your
be,
second
but
case?
it can be, sir. It can be if there is some recurrence from the same side. But in this, my second case was not such because it was later evaluated that the pelvic tract is completely free of the tumor.
Oh. Thank you.
Thank you. Thank you, ma'am.
Thank you, Meghadipa. Thank you, judges. Now moving to our next presentation is by Dr. Arundhati Sheth. She is first year pathology PGT in NRS Medical College and Hospital. Her topic is mesenchymal hematoma of liver, diagnostic challenge. Arundhati, are you ready? Please share your screen.
Yes, ma'am, I'm ready. Am I audible?
Yeah, you are audible.
Good afternoon to my respected teachers.
Please
and fellow
share the screen. Share your screen, please. We can see your face, but not the slides. Yeah, it's coming now. Thank you.
Good afternoon to my respected teachers and fellow colleagues. I am Dr. Arundhati Sheth, second year PGT of Department of Pathology, NRS Medical College. Today I am going to present my e-poster on mesenchymal hematoma of liver, a diagnostic challenge. I have done the study under guidance of Dr. Moumita Maiti and Dr. Ranu Sarkar ma'am of our own pathology department. Mesenchymal hematoma of liver is a rare hepatic lesion affecting mainly children. It is very rare. The incidence is 0.7 cases per million population per year, and it makes up 6% of all pediatric tumor. It is the third most common pediatric liver tumor after hepatoblastoma and infantile hemangioma. In 85% cases, it occurs within 3 years of life, but in majority of cases, it is diagnosed in first year of life. It most commonly occurs in boys. The etiopathogenesis of the tumor is poorly understood, but multiple studies have reported that there is a balanced translocation on chromosome 19q13.4. Today, I am going to present a 1-year-old female child with history of progressively increasing abdominal swelling with mild pain and discomfort. Her blood reports were normal, except her serum alpha-fetoprotein level was markedly high. She was clinically diagnosed as case of hepatoblastoma. Her CECT of abdomen reveals a large, mostly solid mass arising from left lobe of liver, suggestive of hepatoblastoma or sarcoma. After resection of the tumor, the gross specimen was large, spherical, uncapsulated, and well circumscribed. Histopathological examination shows loose connective tissue composed of spindle fibroblast, thickened blood vessel, proliferative bile duct in a myxoid background. Few areas of extramedullary hematopoiesis also seen. Seeds of proliferative hepatoblast also seen. Few cysts filled with eosinophilic material also seen. The histopathological examination confirms the diagnosis of mesenchymal hematoma of liver. The diagnosis is very difficult due to its non-specific clinical symptom and no definite laboratory parameters is here. In some cases, elevated alpha-fetoprotein may be seen. The tumor diagnosis is delayed because if they are big enough to cause abdominal distension or a compression effect on surrounding structure may seen. In some rare cases, malignant transformation to undifferentiated embryonal sarcoma has been reported. Differentiating between mesenchymal hematoma and other malignant tumor like hepatoblastoma or embryonal sarcoma is difficult based on clinical examination and imaging only. The precise diagnosis relies on the proper histopathological examination. Because of the risks of recurrence and malignant transformation, the gold standard for diagnosis and treatment is complete resection of the tumor. So here I end. Thank you for listening.
Nice presentation, Arundhati. Can you tell a few different histological differential diagnosis of mesenchymal hematoma?
Sir, mixed mesenchymal epithelial hepatoblastoma or undifferentiated embryonal sarcoma or biliary duct adenoma, infantile hemangioma, etc.
Okay. And this alpha-fetoprotein, increase of alpha-fetoprotein, is it necessary to diagnose?
No, sir. Most of the cases, alpha-fetoprotein not raised. In some few cases, alpha-fetoprotein raised in mesenchymal hematoma of liver.
Ma'am, please.
Okay. Can you tell me, Arundhati, what are the origin of hepatocytes within this mesenchymal hematoma?
Hepatocyte.
Yes, you told me now that there are hepatocytes within it.
Sir, ma'am, hepatoblast, some
Okay,
hepatoblast
but what are the
also
origin?
seen.
Okay. Why?
Yes, sir. Ma'am, stellate cell or ito cell of liver. Ito cell.
Can you find hepatocytes within mesenchymal hematoma?
No, ma'am. Hepatoblast, I will find seeds of proliferative hepatoblast without acinar architecture.
Okay. And what are the origin of them? Okay.
Don't know.
So you were telling that in some cases of mesenchymal hematoma, alpha-fetoprotein level is increased, but in most cases it is not increased so much. Why that is so? In which cases alpha-fetoprotein level will be increased and in which cases it is not increased so much? Can you tell that?
No, ma'am.
Okay, fine.
Thank you, ma'am.
Thank you, judges. Thank you, Arundhati. You have finished before time. And so we are moving to our next presenter. That is Dr. Abhishek Datta. He is pathology PGT in IPGMER Medical College, Kolkata. His topic is squamous cell carcinoma in a 6-year-old boy with xeroderma pigmentosa, a rare case report. Yes, Abhishek, you can start.
Okay, am I audible and visible?
You are audible, visible. Please share your screen. Yeah, you have shared your screen.
Okay, I'm starting. Good afternoon, everyone. I will start with the introduction. Xeroderma pigmentosum is a rare autosomal recessive xerodermatosis, worldwide incidence of which is 1 in 2.5 lakh population. It is characterized by solar skin damage with photosensitivity, premature xerosis and aging of skin, photophobia, early onset freckling, followed by cutaneous malignancies over sun-exposed areas of skin at an early age. There is cellular hypersensitivity to ultraviolet radiation due to deficient nucleotide excision repair of DNA damage. 8 complementation groups have so far been identified, XPA through XPG and XP variant. These patients have more than 10,000 times increased risk of skin cancers like basal cell carcinoma, squamous cell carcinoma, melanoma. The mean age of onset of skin cancer is very low, which is 9 years only, and it is about 50 years earlier in comparison to general population. Incidence of multiple primary skin cancers are also common. There are also reports of 10 to 20 times overall increased risk of internal neoplasm development in these patients in comparison to general population. These patients can also develop some neurological abnormalities. Here we are presenting a case of xeroderma pigmentosum with well-differentiated squamous cell carcinoma at over the scalp at the age of just 6 years. Now, case report: a boy presently aged 6 years with an unaffected elder female sibling of 10 years and absence of history of consanguineous marriage between his parents had presented to the skin OPD with complaints of developing hyperpigmented spots over the sun-exposed areas of his body since the age of 3 years. He had history of acute sunburn all over his body except armpits and perineum. He also suffered from photophobia with redness and watering of eyes. Based on the clinical features, provisional diagnosis of xeroderma pigmentosum was made and the patient was advised photoprotection. He was put under regular follow-up at skin and eye OPD. XP gene study was advised, but his parents could not afford the study. Number and size of the lesions kept on increasing with the age of the patient. And at 6 years of age, he presented with a non-tender ulceroproliferative nodular growth measuring 4 cm by 3 cm over his scalp, for which he had to undergo white local excision followed by autologous skin graft repair at the Department of Plastic Surgery. Histopathological examination confirmed the diagnosis of well-differentiated squamous cell carcinoma. Clinically, the patient has now been diagnosed as a case with 3rd and final clinical dermatological stage of xeroderma pigmentosum. He is under necessary follow-up therapy. So far, he has not yet developed any neurological features. Now, moving on to the images, figure 1 and figure 2 are showing the images of the patient. Figure 1 showing the ulceroproliferative nodular growth over the scalp of the patient. Figure 2 showing after the wide local excision of that lesion. In both the images, we can see freckles involving the trunk, upper extremities and face, and also the scalp of the patient. Figure 3 and figure 4 are showing the histopathological evidence of well-differentiated squamous cell carcinoma at 40x magnification and 100x magnification respectively. Now, discussion: both genetic and environmental factors play important role in clinical manifestation of xeroderma pigmentosum. There is marked clinical and molecular heterogeneity. Diagnosis is based on clinical features and is confirmed by DNA sequencing. There are 3 recognized stages of the clinical dermatological manifestation. First stage manifests as photosensitivity with slight diffuse erythema associated scaling, hyperpigmentation resembling freckles. Second stage manifests as chronic severe actinic damage to skin. And the 3rd and final stage manifests as malignant skin tumors, mostly skin cancers. Ocular features can range between photophobia with chronic conjunctivitis to keratitis, cataract formation. Even ocular malignancies can occur. About 25% of the patient can develop neurological features such as mental retardation, microcephaly, hypodysplexia, spasticity, sensory neural hearing loss, seizure. Even CNS tumors can also occur. These patients have shortened lifespan mainly due to progressive cutaneous malignancy with or without associated visceral malignancy. The average life expectancy is around 37 years and 29 years without and with neurological features respectively. Differential diagnoses include trichothyroid dystrophy, Cockayne syndrome, Rothmund-Thompson syndrome, Bloom syndrome, dyskeratosis congenita, severe photosensitivity induced by drugs like voriconazole, porphyria. Management include early diagnosis, lifelong protection from UV radiation exposure, early detection and treatment of neoplasms. Conclusion: this is a clinically diagnosed case of xeroderma pigmentosum which has gone into the 3rd and final stage of clinical dermatological manifestations as evident by development of well-differentiated squamous cell carcinoma over the
Abhishek,
scalp.
you have 1 minute left. Yeah.
which is confirmed by histopathologic examination by us. And this patient also has mild ocular manifestation, which include photophobia and chronic conjunctivitis. And this patient has so far not developed any neurological symptoms related to the xeroderma pigmentosa. Genetic study can help in determining the exact genotype of this patient, which might be helpful in predicting the neurological manifestation which may occur in the future in this patient. With proper adoption of management protocols, we can hope to prolong the life expectancy of this patient. Thank you so much.
So it is nice presentation, obviously. So now you were telling that this patient had no neurological symptoms, right?
This patient had no neurological symptom, ma'am. Yes.
Okay, so do you know that this xeroderma pigmentosum have several variants?
Yes, ma'am. It has got many variants. It has got mainly 8 variants so far, XPA to XPG, and also a variant called XPV, XP variant.
Okay, very good. So now can you tell me in which of the variants these neurological symptoms are least?
Ma'am, in XPC, XPE, and XP variant, XPV, in these 3 genotypes, neurological symptom less or absent.
What is the importance of this XPV?
XPV, there is, ma'am, this is a variant. There, the nucleation excision repair is all right. The nucleation excision repair is done properly, but there is a problem in polymerase, DNA polymerase. There is a special type of DNA polymerase which is called polymerase eta, which is in case mutated. As a result, there is problem in DNA polymerization during of the damaged DNA replication. As a result, the disease manifestation occurs, ma'am.
Actually, what is the manifestation? What is the difference in manifestation in this variant?
Ma'am, difference of features are more or less similar to xeroderma pigmentosum classical, but there is no defect in DNA excision repair damage.
That is genetic. That is genetic. That you have said nicely. Do you know what is the difference in presentation, or is there any difference in presentation?
Ma'am, that I cannot say, ma'am. I think.
Okay, fine.
Very nice, Abhishek. You have studied a lot about XP. And can you tell what is the dermatological as well as histological differential diagnosis of xeroderma pigmentosum? First of all, dermatological, any?
Dermatological manifestations, this will include trichothiod dystrophy. This will include Cockayne syndrome, diseases that are associated with early onset photosensitivity like Lotman-Thompson syndrome, Bloom syndrome. There will be also dyskeratosis congenita. These will fall under the diagnosis. Also, the drug-induced photosensitivity like voriconazole drug-induced photosensitivity. Porphyria can also be a differential diagnosis. And histological differential diagnosis, sir, can be also actinic keratosis can be a diagnosis, histological diagnosis. And also any other malignancies can be diagnosis. Actually, actinic keratosis can be diagnosis, or any other sort of disease that will involve the solar damage to the skin or will be associated with skin cancer can be differential diagnosis, sir.
And what are the common visceral malignancies in XP?
Visceral malignancies, sir, this includes leukemia, can be CNS carcinoma, oral cancers can be there, cancers involving the uterus, cancer involving the testicle. This can also be the malignancies which can be seen in viscera, sir.
Okay.
Very wonderful presentation by Abhishek Datta. Thank you, Abhishek. Now moving to our next presenter is by Dr. Sukanya Ghosh, and she's from Arjikar Medical College. Her topic is metastatic deposit of melanoma arising from congenital nevus mimicking a primary parotid neoplasm in a 36-year-old male patient. Results of fine needle aspiration cytology reorienting the clinician's approach. Ma'am, Dr. Sonia ma'am and Dr. Shubhalakshmi ma'am. Ma'am, are you all there, ma'am?
Yes, I'm there.
Okay, ma'am. Ma'am, shall we start? Dr. Sukanya Ghosh, are you ready?
Yes, am I audible?
Yeah, you are audible. Please share your screen.
Is it visible?
Please zoom it. Yeah, this is visible. Okay.
Okay. Good afternoon, respected judges. Today my topic is metastatic deposit of melanoma arising from congenital nevus mimicking a primary parotid neoplasm in a 36-year-old male patient. Now coming to my topic, 80% of all salivary gland tumor develop in parotid gland and 25% of them are metastatic and originate in the head and neck region. Now, malignant melanoma is a well-known diagnostic pitfall given its propensity to metastasize to different sites and mimic various entities. Squamous cell carcinoma followed by malignant melanoma are the most common type of cancers with metastasis to the parotid gland. In this era, fine needle aspiration cytology is the preferred diagnostic method in the primary investigation of pathology of head and neck, especially of parotid and thyroid lesions. Now, in this case report, a case is presented with that of a metastatic melanoma occurring in preauricular or parotid area in parotid group of lymph nodes, which was otherwise the original case of cutaneous melanoma, which arose in a background of congenital nevus in a 36-year-old patient while evaluating a suspected primary parotid neoplasm. Now, this 36-year-old patient presented with a firm left-sided preauricular swelling for 3 months, which was fixed to the underlying structures. Now, taking history, we found out that there had been an acute attack of ERA 3 months back, for which a course of antibiotic had been administered. But however, the small swelling gradually enlarged and eventually transformed into a firm hard swelling after a repeat course of antibiotic. Now, this initially pointed towards formation of a bezold abscess, transforming into antibioma as a complication of acute suppurative otitis media, which is, however, also an unusual occurrence in this age group. So, FNAC was performed, and the patient by far had not come with, without any imaging report. So, he was advised 1. However, on FNAC, the smear showed a very high cellular yield, comprising dispersed neoplastic cells with marked atypia in a background of necrosis. The cells had basophilic cytoplasm with brownish intracytoplasmic pigment. Also present were marked degree of nuclear pleomorphism with prominent eosinophilic nucleoli associated with bizarre-looking multinucleated giant cells. The cytomorphism suggested classical melanoma, but taking into account the patient's age, location, and ominous prognosis, we hesitated to disclose the diagnosis. Initially, no apparent primary lesion was obvious, from which he could have suspected any metastasis to preauricular parotid group of lymph nodes. There also could have been a possibility of a primary neoplasm of parotid also. So, in the next visit, another aspiration was performed, and specimen was sent for cell block preparation and immunohistochemistry. This time, on careful examination, we discovered a dark nevus in the forehead at the same site, hidden beneath the hairline. However, the patient told us it had been present since birth without any noticeable change in the years. As we examined closely, one corner of the lesion showed an evolving
Sukanya,
area
you have 1 minute left.
with irregular border, variegation in color, accompanied by satellite nodule, pointing towards emergence of an invasive melanoma in a background of congenital nevus. Biopsy from this region on forehead confirmed the diagnosis, and immunohistochemistry on cell block showed S100 positivity. Now, malignant melanoma rarely affects the parotid, and usually the diagnosis will herald a search for primary skin neoplasm, raising the question regarding the prognosis and primary neoplasm of the parotid. So, timely diagnosis, early detection can prompt adequate treatment in the view of poor prognosis. Thank you so much.
Judge. Yes.
Hello. Kanya, it was a nice presentation. What could I understand was that this was a case of a congenital melanocytic nevi, and then it has transformed into a melanoma, and it has metastasized to the preauricular group of lymph nodes, right?
Yes, ma'am.
Okay. So can you tell me which congenital melanocytic nevi can have a malignant transformation like this?
Ma'am, congenital melanocytic nevus or melanoma arising from the category of the melanoma arising from the congenital nevus category.
Which one? Can you name them? Okay, can you tell me the gross features of a congenital melanocytic nevi which has a propensity to undergo a malignant transformation? What will be the gross features? How can you on clinically diagnose that yes, this congenital nevi is going to have a malignant transformation?
Ma'am, there will be asymmetry of the and the borders will be irregular.
Yes. What else?
Ma'am, variegation of color.
Yes. What else? What about the size?
Ma'am, it could be oval shaped or round and usually raised.
What about the
It
size?
can be a tiny spot or it can be even larger than that.
Does a size, can you tell me the numerical value of the size of a nevi which shows a propensity towards the malignant transformation, whether it is more than 10 centimeter, less than centimeter, or something like that? Can you tell me?
Ma'am, it had to be more than 4 millimeter.
4 millimeter?
Yes, ma'am. Yes, ma'am.
Okay, can you tell me what a blue nevi is? Okay, thank you, Dr. Sukanya.
Thank
It
you,
was a
ma'am.
wonderful presentation.
Hello. Hello. I have a question. May I ask my question?
Yes,
Yeah.
yes.
Thank you for your nice presentation, firstly. Now, I just wanted to know that biopsy from the your preauricular lymph node you're talking about. Did you do it? You did the
Biopsy from the
FNAC?
biopsy from the nevus.
From the primary, yes, that
Yes,
you did.
not from the
From the lymph
preauricular.
node, you did only FNAC, no?
Yes, yes.
Right. Now, can you tell me the types of metastasis we can expect from a melanocytic malignant lesion or melanoma? What are the types of metastasis? The reason behind this question is that is this the what is the expected site where a melanoma may metastasize, which is located in the skull?
Ma'am, because the parotid region is a echelon of the first site where a the lymphatic drainage. So first it comes to the parotid group of lymph nodes. The primary melanocytic lesion from the forehead and scalp region.
Okay. Thank you so much.
Thank you, ma'am.
Yeah, thank you, Sukanya, and thank you, judges. Now, coming to our next presenter, Dr. Shritama Sarkar. She's a postgraduate trainee from KPC Medical College and Hospital. Her topic is lateral cell angioma of the spleen, an uncommon case. Shritama, please share your screen.
Yeah, I've shared it. And am I visible and audible?
Yeah, you are visible, you are audible. Please start.
Good afternoon, respected judges. Today I'll be presenting my poster on lateral cell angioma, an uncommon case, under the guidance of Dr. Raghunath Chatterjee, Dr. Sujata Malik, Dr. Mala Banerjee, Dr. K. Basu ma'am, from the Department of Pathology of KPC MCH. Lateral cell angioma is a rare vascular tumor unique to the spleen. Lateral cell angioma was first described in 1991, varies in size from minute foci to large nodules, almost completely replacing the splenic tissue. LCA can occur at any age and has no gender predilection. In an article of 2015, a total number of 110 cases have been published in the literature, with 4 published pathological series and 3 published case series. Here in the first image, we can see the CT scan image showing a hypodense splenic lesion. And then how does the spleen look macroscopically? Next, coming to the case report, a 49-year-old male patient presented with constitutional symptoms, including low-grade fever, fatigability, and weakness for last 2 years, which gradually were increasing for the past 6 months. Physical examination was unremarkable except for mild pallor and splenomegaly. All investigation in marrow study and endoscopy were non-contributory. Splenectomy was done to look for isolated low-grade lymphoma of spleen. Coming to the pathological findings, on macroscopy, the spleen was enlarged, measuring 22 along the splenic axis. The outer surface was irregular. The outer surface was irregular and nodular. On cut section, the surface was brownish with numerous distinct gray tan nodules varying in size from very tiny, measuring less than 0.5 centimeter to 3 centimeter in greatest dimension. On microscopy, multiple discrete nodules were seen having anastomosing narrow vascular channel interspaced with dilated cystic spaces and pseudopapillary foci. The vascular channels were lined by plump, bland-looking cells, some of which have exfoliated into the lumen. These cells were CD68 positive. Rest of the spleen showed normal CD20 positive B cells forming follicles within the white pulp. CD3 positive T cells were distributed as usual throughout the splenic parenchyma. In the figure, we can see CD3 positive T cells distributed throughout the parenchyma, and next image, there is CD20 positive B cells forming follicles. Next, coming to the discussion, lateral cell angioma is a vascular tumor unique to the spleen, originally thought to arise from normal splenic lining lateral cells. It has been found to affect both men and women in an equal distribution. Given the relative lack of symptom specificity, LCA is often found incidentally as a splenic mass on abdominal imaging. However, 2 cases of LCA presented with splenic rupture and hemoperitoneum have been reported. The sonographic appearance of LCA is variable. It ranges from hyperechoic to hypoechoic mass in an molted texture. On contrast-enhanced CT, LCA is isodense to slightly hypodense in comparison to the surrounding splenic parenchyma in both the arterial and early portal venous phase. Magnetic resonance imaging characteristically shows T1 and T2 hypointense mass. It can be multifocal and variable in size. The differential diagnosis of lesion that can mimic LCA imaging includes lymphangioma, hematoma, lymphoma, Kaposi's sarcoma, and hemangioma. Therefore, a definite diagnosis can only be obtained by histopathological evaluation. It varies in size from minute foci to large nodules, almost completely replacing the splenic tissue. Microscopically, it is composed of anastomosing vascular channels resembling splenic sinuses. These channels have irregular lumina, often featuring papillary projection and cyst-like spaces. They are lined by tall endothelial-like cells, some of which may show hemophagocytosis. Immunohistochemically, LCA is characteristically CD34 negative, CD68 positive, CD21 positive, and CD8 negative. Additionally, the epithelial cells in LCA do occasionally express S-hybrid protein. FHOD1 protein is expressed by normal lateral cells, not by LCA. High expression of FHOD1 distinguishes lateral cells from LCA. LCA is a rare vascular tumor of splenic.
Shitama, 1 minute is over. 1 minute is left now.
And is typically an incidental finding on abdominal imaging. The appropriate treatment is splenectomy. Longitudinal surveillance in the post-operative phase is recommended. Here in the images, we can see positive CD68 cells. Coming to the conclusion, Littoral cell angioma is uncommon and should be considered and excluded in splenomegaly with constitutional symptoms. Any case having nodules in spleen and showing vascular proliferation should be subjected to immunohistochemistry to rule out this rare entity. Thank you all.
Wonderful presentation, Dr. Shritama.
So much, ma'am.
Now, you have mentioned that on the gross appearance, there were numerous nodules
Yes, ma'am.
from very minute to size up to 3 centimeter. You have
Yes,
not shared any cut section pictures here. That is why I'm asking you this. Do you know any other variants in the gross appearance of this tumor?
Ma'am, actually, it should be having distinct nodules, and the spleen will increase in size. There will be splenomegaly.
On cut surface, apart from gray to tan nodules, you have mentioned about the solid nodules. Is there any other gross appearance by which this tumor can present?
Ma'am, I don't have much idea about it.
Okay. The second question is, you have mentioned in your microscopic features that sometimes the epithelial cells which are present within the tumor may show S100 positivity. So
Yes,
what
ma'am.
are these epithelial cells are?
Ma'am, these epithelial cells I meant is littoral cells. These littoral cells show S100 protein positive because littoral cells share the same lineage as a macrophage, and S100 protein is an important regulation for macrophage inflammation.
So my other question is then, is littoral cells normally present inside the spleen? And if yes, where is it actually present normally?
It is normally present in the spleen, and it is the lining cells of the sinuses.
Lining cells of the?
Red pulp sinuses.
Red pulp sinuses. Okay. Thank you. Good presentation.
Thank you, ma'am.
My question is,
yes, ma'am.
I have one question, Shritama, that what is the explanation behind the constitutional symptoms in this case?
Ma'am, explanation is there was splenomegaly, and the patient was facing symptoms like low-grade fever, fatigability, and weakness for like 2 years. He went through many tests, and finally there was no positive outcome of any of these. Finally, he decided to go for a splenectomy to rule out the possibility of low-grade lymphoma. And after the spleen was sent to our department, it was eventually found out that it is a case of littoral cell angioma by doing the IHC marker.
All right. And by histopathology only, without
Yes,
any other marker, can you actually make the diagnosis of littoral cell angioma?
Ma'am, with the help of markers?
Without help of markers, what are the disease? What possibilities come to your mind when you examine the slide?
Littoral cell angioma is one of those cases where histopathology play a very important role. By seeing those littoral cells that were coming to the lumen, like that various that were interspaced in anastomosing vascular channels, interspaced cystic dilated spaces, and pseudopapillary foci, and some cells, bland-looking plum bland cells, were exfoliated in the lumen also. Seeing all those, we suspected that it can be a littoral cell angioma. Then we went for the IHC and went for CD68. So it was CD68 positive.
All right. And regarding gross, is it very common that the gross features that you have seen in your specimen, is this a common feature for this littoral cell angioma, this diffuse involvement by multiple nodules?
Yes, ma'am. This is a general feature.
What other condition would be a differential diagnosis? If you examine the gross specimen only, looking at the cut section of the spleen, what other possibilities would come to your mind?
Ma'am, possibilities like hemangioma can come to my mind, lymphangioma can come, hematoma, Kaposi sarcoma, all this might come to my mind.
Multiple your nodular lesions involving the whole spleen. Are they the disease in that case? Anyway, your case is an excellent one and your presentation is good.
Thank you, ma'am.
Okay. Thank you, Dr. Shritama. Very nice
Thank you, ma'am.
presentation. Now moving on to our next presenter, Dr. Sudeep Kumar Pore. He is from Arjikar Medical College and Hospital. His topic is granular cell tumor array case report. Dr. Sudeep, are you ready?
Yes, I am ready. Am I audible?
Yeah. Yes, you are audible. Please share your screen. Okay. Dr. Sudeep, please share your screen.
Yes. Is it visible?
Yeah, it's visible, but you have to just little move it to the left side.
Okay.
Yes. Yes. Now we can see it. Please start.
Yes. Okay. Good afternoon, respected judges and audience. Today I am presenting my e-poster on granular cell tumor of arm in a young adult, a rare case report. Let's start. A 26-year-old female presented at Department of Surgery with history of painless soft tissue mass lesion over lateral aspect of little left arm for duration of 6 months. There is no history of trauma or surgery at site of tumor. MRI report revealed an ill-defined mildly hyperintense lesion measuring 14 to 3 centimeters in lateral aspect of left arm and infiltrating the superficial fiber of muscle. Wide local excision of mass was performed and sent for histopathological examination in our department. We received the specimen. Grossly, specimen was grayish-brown skin-covered tissue piece on cut section showed 3 into 2.5 into 1.5 centimeter, one solid grayish-white growth at subcutaneous plane. Microscopic examination showed ill-defined tumor composed of nest and seeds of large oval to round cell separated by thin collagenous band. Individual cells having abundant finely granular eosinophilic cytoplasm and small centrally placed rounded nuclei. Perineural invasion was seen at one focus. No mitosis or other features of atypia are seen. In my poster, figure 1 showing the gross finding of tumor and figure 2 and figure 3 showing histopathological features suggestive of granular cell tumor, as I have said earlier, and figure 4 showing the perineural invasion at one focus. For further confirmation and differentiate for other tumor having similar histological features, immunohistochemistry for S100 and myodion was performed. S100 was positive and myodion was negative. So we came to the confirmation of diagnosis of granular cell tumor. Now come to the discussion. Granular cell tumor is rare and mostly benign neoplasm. It may involve any organ of the body and involve most commonly head and neck area, about 50% case, most commonly occurring in 4 to 6 decades of life. Immunohistochemical studies showed that it has a swan cell origin through positive identification of S100 protein. Malignant granular cell tumor is extremely rare and that occur in only 1 to 2% case. In a rare occasion, it can metastasize on when they become malignant. Feature favoring malignant are presence of necrosis, high mitotic activity, spindling of the tumor cell, vesicular nucleus and large nuclear pleomorphism, and Ki succession proliferation index more than 10%. Though it was located in not so common area that was earned, it has been differentiated from other tumor with similar histological features. It should be differentiated from other tumors like rhabdomyoma, fibroxanthoma, alveolar sarcoma, as well as reactive histiocytic proliferation in site of trauma or surgery. In that case, the operation was done 2 months back. Now patient is under regular follow-up. Since the operation, patient is disease-free without any complication. Now come to the conclusion. Although granular cell tumor are uncommon and mostly benign, they have a tendency to metastasize or malignant transformation. And also, recurrence can occur after incomplete excision. Wide local excision is treatment of choice. It has is resembling some other tumor. Hence, proper histopathological evaluation along with immunohistochemistry is needed for correct diagnosis and avoid unnecessary over or under treatment. That's all. Thank you for presentation and to present my hearing.
Thank you, Dr. Sudhir. Well presented.
Thank you, ma'am.
I want to know here whether the patient, you just received the specimen and then you have asked about the past history from the patient, right?
Okay, yes, ma'am.
Yes. So what was the past history like since how long the mass was present, whether the patient has undergone other
Master
investigations?
usually patient noticed the mass for last 6 months when he had visited the surgery OPD. And they have the examine and my MRI reporting shows the ill-defined and highly high-index lesion, and they had decided the wide local excision of mass, and we received the specimen, and we histochemical report shows that it's a granular cell, suggestive granular cell tumor, and
So
compared by
no other
ethanotic positive.
investigations was done before wide excision? No, apart from radiological, that too you have
Usually,
mentioned the MRI. Apart from that,
yes.
no other investigation was done before
Usually,
wide
usually the surgery department will send a patient two-card biopsy. The two-card biopsy shows the possibility of a granular cell tumor.
No X-ray, no FNAC?
No, only two-card biopsy was done previously.
Okay.
Before total excision of the mass.
Okay. This another question is like the granular cell tumor can have a wide spectrum of presentation, you know, from benign to malignant. Can you tell me, like, on the gross appearance or on the characteristic of the tumor, can you tell me which tumor is likely to undergo malignant transformation and which is not?
Sometimes the tumor size is more than 5 centimeter in diameter. It has a tendency to malignancy on feature size. The history of the size, range of necrosis or mitotic feature is high. It's a feature of malignancy. And also there is a nuclear pleomorphism, vesicular nucleus is a feature of malignancy. It did not see that in my section exam.
I'm asking about the gross features, gross presentation, and the characteristic of the tumor, not the microscopic features.
Grossly, it was usually less than the 5 centimeter in diameter, and it looks like a whitish growth and ill-defined margin. It is more in diameter and also presents a more granular appearance, more tan-like appearance, is more suggestive of the malignancy.
Okay, can these tumors be multicentric, or they are focally present?
Maybe multicentric. In 10% case, it may be multifocal or multicentric.
So do multicentric undergo a quick malignant transformation, or they behave benign throughout its course?
Maybe transfer into malignant transformation, maybe.
You are not sure. Okay, thank you, Dr.
Not
Sudhir.
sure.
Thank you, Dr.
Okay,
Sudhir.
thank you, ma'am.
Any other questions from judges now? Shall we move on to next presentation? Okay. Now, our next presenter is Dr. Suman Sardar. She is from Arjikar Medical College and Hospital. Her topic is rhinocerebral mucormycosis, a notorious entity in post-COVID era. Dr. Suman, please start your screen sharing.
শুভলক্ষ্মী তো ছিল ওখানে শুভলক্ষ্মী ম্যাডাম is there.
Okay, ma'am. Ma'am, you had any question from previous presentation?
শুভলক্ষ্মী ম্যাডাম is there.
Yes, ma'am.
Am I audible?
Yeah, you are audible.
And is my screen is visible to all?
Yeah, it's visible.
Okay, thank you. Good afternoon, everyone. As my topic is rhinocerebral mucormycosis, a notorious entity in post-COVID era. So, at first, a small introduction about mucormycosis. Mucormycosis represents a group of life-threatening infection caused by fungi of the order Mucorales of the subphylum Mucormycotina. Mucormycosis is highly invasive and relentlessly progressive, which resulting in higher rate of morbidity and mortality in comparison to many other infections. Fungi of the order Mucorales belongs to 7 families, all of which can cause mucormycosis. Among them, Rhizopus oryza and Rhizopus delimar are the by far most common. Mucormycosis is an opportunistic fungal infection which is most commonly found in immunocompromised patient and also patient with uncontrolled diabetes mellitus. The ongoing pandemic of COVID-19 has further reinforced the importance of mucormycosis as an opportunistic infection. Rhinocerebral, orbital, and lung are the most common location. Here we report 2 such cases of mucormycosis with past history of COVID-19 infection. They are presented with rhinocerebral and orbital infection. In first case, it's a case of 45-year male presented with fever, sinus congestion, and black necrotic lesion of the nose with a past history of COVID-19 infection. His CT-PNS showed aggressive acute rhinosinusitis on the left side with intracranial extension and also having dural enhancement in the anterior superior part of the left salvian fissure. The biopsy was taken from left nasal mucosa. In second case, the case of 52-year non-diabetic male presented with fever and sinus congestion. He also had a history of COVID-19 infection in past. His MRI PNS show ill-defined hypointense lesion in the left side of sphenoid sinus and middle terminal. Biopsy was taken from the middle terminal. In both the cases, histopathological study demonstrate extensive necrosis, dense non-specific inflammatory cell infiltrate, and scattered fungal element with broad accepted hyphae with occasional branching at right angle. The confirmatory diagnosis of mucormycosis was given after periodic acid sieve and gomorymethanamine silver stain. So, as the COVID-19 patient always have immunosuppression with decreased CD4 and CD8 T cell, there are various possible reasons for association, including the disease process of COVID-19 itself, or one of the factor may be extensive use of steroid. Mucor is a saprophytic fungus which exists widely in the nature, but for its low virulence, it may remain as a common cell in nasal mucosa of a person. If the patient became immunosuppressed, it germinated and spread to the nearby structure. Biopsy and histopathological study remain the most sensitive and specific modality for definitive diagnosis. The species of Mucorales is only identified by culture. Polymerase chain reaction is being investigated as diagnostic tool for mucormycosis, but not yet approved. So in conclusion, the question still prevail about the cause and origin of enhanced prevalence of mucormycosis in post-COVID patient. So prevention and management of mucormycosis in post-COVID, use of prophylactic immunosuppression should be more judicious along with continuous monitoring. Thank you.
Hello, am I audible? Am I audible?
Yes, ma'am.
Okay, my question is, what was the time gap between the COVID-19 infection and mucormycosis in these cases?
In these cases, madam, it's one case is about 2.5 months and one is 3 months.
And another thing is, did they receive steroid during?
Yes, ma'am. Yes, ma'am. Both of them receiving steroid. As a prophylactic measures, they are receiving steroid.
Okay, that's all.
Okay, ma'am.
Dr. Shuman, it was a wonderful presentation.
Thank you, ma'am.
Can you tell me whether both the patients received any kind of oxygen therapy? What was their oxygen saturation levels at the time of their
Ma'am, when they are first infected with COVID, diagnosed with COVID-19, their saturation level was below 70% and they are admitted in CCU in our hospital. After the discharge, 2.5 months, they again came with that I discussed as early the mainly with fever, mild fever and nasal congestion, sinusitis. That is the symptoms when they are represent with when they represent next time. Further time the mucormycosis was diagnosed. That time they represent with nasal congestion, sinusitis and fever. But this time they don't have COVID. They are COVID-19 negative this time.
Okay. And what type of oxygen therapy and which equipment was utilized for giving the oxygen therapy? You know about
They give BiPAP, ma'am.
okay.
BiPAP was.
Both the patients received BiPAP.
Yes, ma'am. Yes, ma'am.
Okay. And you said on microscopically the hyphae were aseptate, but some of them were branching at right angles.
Ma'am, Aspergillus has septate and acute. They are in Aspergillus they are septate and they have acute angle. But in case they are aseptate, mucormycosis is aseptate and broad, and if there is any that is on 90-degree angle.
So, and any other aseptate hyphae, any other fungi which shows aseptate hyphae and branching at 90-degree angle?
Ma'am, Candida. No, ma'am, no.
Okay, how will you differentiate between a aseptate and a septate hyphae? It's a common question, I suppose.
Ma'am, it's only by staining we can under microscope we can see that septa. I will show you, ma'am. In my picture, the difference between
you can bring your poster up because it is not showing. The whole of the poster is not visible. Yes.
Ma'am, these are the broad accepted hyphae, and if there is septate, then it will look like. Ma'am, H&E stain can show the septa and accepted hyphae. We can
many stains. I am asking you the main difference between a septate and a aseptate hyphae. What about the wall? How do they septate? Okay, so in this, you have used the silver staining also.
Yes, ma'am.
Yes, you did it yourself.
We PA stain we did it ourselves, but GMS stain was with the help of the microbiology department.
Okay, can you tell me the steps involved? Which is more suitable for histopathological? Which silver stain is more suitable for? There are two types. There are two methodology involved for doing a silver stain, right?
Yes,
which methodology is more appropriate for a histopathology slide? Because you've done it on an histopathology slide. That is why I'm asking you this.
Sorry.
Okay. Okay. Thank you. Thank you, Dr. Suman. It was wonderful presentation.
Thank you.
Okay. Thank you, judges. And thank you, Dr. Suman, for your wonderful presentation. Now, moving on to our next presentation is by Dr. Sampriti Putendi. She is third year junior resident Department of Pathology from Medical College, Kolkata. Her topic is primary stromal sarcoma of breast, a diagnostic dilemma. May I request the judges, Dr. Barnik Chaudhary, sir, and Dr. Tarak Barnik, sir, to join? Sir,
yes, we are here. We are here.
Yes, sir. Thank you, sir. And Sampriti, you please share your screen. Yeah, we can.
I am already shared.
Yes, please show your
audible?
full screen. Yeah, you're audible. I request you to show your full screen, okay? While presenting. You can scroll it down also later on.
Just a second, it's not going. Just a second. I will do a bit later on, okay?
Okay, you can scroll it down later on. Okay, you can start.
Okay.
Thank you.
Okay. My topic of presentation is primary stromal sarcoma of breast, a diagnostic dilemma. Primary stromal sarcoma of breast are a group of rare and heterogeneous tumors that represents approximately 0.2 to 1% of all primary breast malignancies and less than 5% of all soft tissue sarcomas. There is an increased risk for rapid progression and local or distant recurrences, accounting for a relatively poor prognosis. Histologically, malignant Pillard's tumor and metaplastic carcinoma are their close differentials. Here we present a rare case of primary malignant breast sarcoma in a 47-year-old female patient. True-cut biopsy of the breast mass revealed invasive carcinoma of no special type, and she underwent a modified radical mastectomy. Subsequently, histopathological examination revealed a malignant mesenchymal tumor positive for vimentin and CD10 markers. Our objective of this case to present a rare case of primary stromal sarcoma of breast masquerading as an invasive carcinoma of breast not otherwise specified, and to highlight the differential diagnosis of stromal sarcoma of breast and appropriate ways of reaching a correct diagnosis. Among the investigations, PET CT scan shows the metabolically active large necrotic malignant mass in left breast with involvement of overlying skin. No evidence of distant metastasis is noted. Grossly, the specimen comprises a very hard fungating mass involving all the quadrant of breast with nipple areola complex. Deep resection margins were appeared to be involved by the tumor grossly. On microscopic examination, the tumor shows composed of numerous haphazardly arranged oval to spindle cells with variation in cellular size. The cell had hyperchromatic nuclei with inconspicuous nucleoli and moderate amount of eosinophilic cytoplasm. Multinucleated cells and cells with bizarre nuclei were also evident. Mitotic count was noted to be 4 to 5, the 10 high power field. In fair number of foci, oval to epithelioid looking cells having the same nuclear morphology was noted. Most probably, the tissue obtained by true-cut biopsy was sampled from the area containing these cells, which prompted the pathologist to diagnose it as an invasive carcinoma not otherwise specified. So, it took the help of immunohistochemical panel consisting of ER, PR, and HER2/neu, Ki67, P63, vimentin, CD10, and CD34 to achieve the proper diagnosis. The tumor cells were positive for vimentin and CD10, and the endothelial cells of the vessels were positive for CD34. The Ki67 index was recorded to be 30%, and other marker yielded negative result for the tumor cells. So, it's in stromal cell sarcoma, it is difficult to diagnose preoperatively due to its rarity and inadequate imaging method to establish an exact diagnosis. The histopathological report guides the management of this tumor. Histologically, the stromal sarcomas are high-grade undifferentiated tumors that do not fit into a specific category of any soft tissue sarcomas. Malignant Phyllodes tumor and metaplastic carcinoma are the close differentials among them. While malignant Phyllodes is diagnosed histologically when its benign counterpart is simultaneously apparent along with the histological compartment to submission of the cases. The lack of resources in many centers may not permit the submission of as many sections to confidently rule out the diagnosis. Metaplastic carcinoma along with other heterogeneous features like sarcomatous component is also present. Again, such extensive sampling as to establish the absence of malignant epithelial component may not be feasible is most of the times. However, immunohistochemical analysis is helpful resolving the issue in most of the occasions. Malignant phylloid tumors are frequently positive for CD34.
Sampriti, you have 1 minute left.
And metaplastic carcinoma are generally positive for CK56 and P63. So here we conclude that any rapidly growing breast mass requires meticulous evaluation. The diagnosis of stromal sarcoma, though rare, should be borne always in mind. However, the final diagnosis must only be rendered after thorough histopathological examination and immunohistochemical analysis. Ma'am, just a second, I can't scroll it down. It's not working properly. The figure 1 is showing is the PET. So, ma'am, is it visible? Hello?
Yeah, it's visible.
Figure 1 showing PET CT image showing necrotic malignant mass in left breast, and figure 2 is showing the gross image of fungating breast mass, and the figure 3 is showing the tissue section of oval to epithelioid cells with spindling at places and severe pleomorphism. Figure 4 showing the
Your time is up, Sampriti.
Thank you.
Hello, is it audible?
Yes, sir, it's audible, sir.
But
Dr.
tell her to continue.
Yes, ma'am. I told her to continue.
Ma'am, I have completed.
Yes, completed.
Yes,
Yes,
ma'am.
ma'am.
She has
Yes, ma'am.
completed. Yes,
Thank
ma'am.
you.
My
Thank you.
share screen is not giving.
Visible. Okay. Okay. Thank you.
Okay, Dr. Shaviti, it was very nice case and a full presentation. I have few questions. Was any FNSC done in this case?
No, sir. The first patient presented with the breast mass, and the previously the FNSC was done in other center, and it shows atypic cells. So we have done the TrueCut biopsy first in our department.
Did you show the TrueCut biopsy image in your report?
No, sir.
Did
I
you
have not included in this poster. But the
you have
TrueCut.
mentioned that
Sir.
you have mentioned that in the TrueCut report as IDC NOS. So
Yes.
now after having the gross, having the mastectomy specimen, you corroborated that finding of this IDC diagnosis on TrueCut biopsy. What was the mistake?
Sir, in IDC, in TrueCut biopsy, we have found the oval to epithelioid looking cells. And in mastectomy specimen, in fair number of foci, we have seen the oval to epithelioid looking cells having the same nuclear morphology, just like a spindle cell in nature. So most probably the tissue obtained by the TrueCut biopsy was sampled from that area of the epithelioid looking cells, which prompted the pathologist to diagnose it as a invasive carcinoma of breast, not otherwise specified. So immunohistochemistry helped us in resolving that issue.
In your this microscope, you have not enlarged that is why it is problematic. Was there any gland, any benign gland visible?
No, sir. We did not see any benign gland. Any ductal component is not seen in mastectomy specimen.
Okay. There are one question. Just how did differentiate it tumor on H and H apart from his mystery? You just give us your opinion how you differentiate from phylloid tumor on A section.
Sir, in phylloid tumor, we can see the at least one area of ductal component, any epithelioid part. But in our cases, we have not seen any ductal or epithelial component. So from histology, we can differentiate from this only.
How many sections have you taken for gross?
Yes, sir.
How many sections? How many sections have you taken from tumor?
Sir, from tumor, we have taken 8 sections.
8 sections. What is the size of the tumor?
Sir, size of the tumor is
What is the size?
Sir, size of the tumor is 7 centimeter in maximum dimension.
Okay. That is the problem that we could take as many sections. That is it could be a case of phylloid tumor because it is more likely than having a small sarcoma. Okay.
Yes, but the ERPR and with this negative.
Yes.
Okay.
Thanks, Tarok. Yes, I agree with you. This appears to be more like a high-grade phylloid tumor to me too, rather than primary stromal cell sarcoma. Is there any immunohistochemical marker which differentiates a high-grade phylloid tumor?
Sir, we have seen in phylloid tumor, it can be, sir, ERPR and HER2/neu positive, but in our case, we have seen it's negative. ERPR, HER2/neu both are negative, and CD10 is positive, is highly, intensely positive in our case. Sir,
ERPR will be positive in benign and borderline phylloids. In high-grade phylloids, it is usually negative. And CD10 may be positive in phylloids also. So that is not a very equivocal marker to differentiate, unequivocal marker to differentiate from malignant phyllodes. Okay. Why you that would be obviously part of malignant phyllodes itself. You wouldn't consider this diagnosis of this undifferentiated pleomorphic sarcoma in this case. Would be my you said multinucleate chances.
Yes, sir.
Anyway, thanks for a nice presentation, Dr. Sampriti.
Thank you, sir.
Thank you, judges. Thank you, Dr. Sampriti, for your wonderful presentation. Now, moving on to our next presentation is by Dr. Aishwarya Basu. She is second year PGT of Medical College, Kolkata. Her topic is plasmablastic lymphoma in retromolar trigon, a rare presentation in an immunocompetent HIV-negative elderly individual. Dr. Aishwarya Basu, please start it.
Am I audible?
Yeah, you're audible. Yeah, you're visible.
Is my poster visible?
Yeah, it's visible, but yes, you have to scroll it down while presenting. Okay?
Yeah, I'll scroll it down. Good afternoon, judges and my fellow colleague. I am Dr. Aishwarya Basu. I will be presenting an e-poster on plasmablastic lymphoma in retromolar trigon, a rare presentation in an immunocompetent HIV-negative elderly individual. Plasmablastic lymphoma is a term first described by Delacluse. It is a rare and an aggressive form of mature B-cell neoplasm, almost exclusively identified in patients infected with human immunodeficiency virus. The small number of HIV-negative PBL cases reported in literature till date are consisting of only single case reports and few small case series. They are mostly presented in the oral cavity mucosa or gingiva. Only a handful of PBL cases till date have been reported in immunocompetent individuals. Here we present a case where an 68-year elderly individual presented at the dental outpatient department with the chief complaint of bleeding from the left lower gum for a duration of 3 weeks. Clinically, a sessile growth was noted in the left retromolar trigon with normal overlying mucosa and peripheral cuffing of bone in the third molar region. Radiologically, an MD-CT scan of neck was done and it revealed an irregular mass at the left cheek extending down to the left lower retromolar trigon. Then an excision biopsy was performed from the lesion, and after histopathological processing and subsequent H&E staining, the light microscopy findings showed, the grossing showed the following result. There were 3 pieces of friable grayish tissue piece. The largest one measures 3.5 centimeter in the greatest axis. On light microscopy, as we can see, the tumor was subepithelial in location. The tumor consisted of diffuse sheets of monomorphic tumor cells. Individually, the tumor cells were large with round nucleus, vesicular nucleus, having open chromatin and the moderate amount of basophilic cytoplasm. There was brisk mitosis and plenty of apoptotic bodies seen. As the histopathological reports were ambiguous, so it showed a malignant neoplasm. We went for an immunohistochemistry panel, which consisted of CD138, MUM1, CD30, 45, 56, kappa light chain, CD20, PAX5, ALK1, CD48, PANCK, MIB index. Now, the tumor showed a strong positivity for CD138 and MUM1, a focal positivity for CD30, CD45, and CD56. There was kappa light chain restriction. The Ki67 index was very high, around 95 to 98%, and the cells were negative for CD20, PAX5, ALK1, CD2, CD4, CD8, and PANCK. The immunohistochemistry picture suggested it to be a plasmablastic lymphoma. In the meantime, we performed the serological reports of the patient, and patient came out to be HIV negative. To look for any metastasis, an MD CT scan of the chest was performed, and it revealed a growth in the lower right middle zone, and it was a pleural-based growth. So I would like to conclude that although it is described as occurring in the human oral cavity in patients with HIV positive patients, PBL can also be identified in patients with other causes of immunodeficiency and in immunocompetent patients. So when an elderly individual coming to the department with a chief complaint of mass in the oral cavity or bleeding from the gum, plasmablastic lymphoma must be considered as a differential diagnosis when it is supported by the microscopy, the aggressive nature of the tumor, radiological evidences. These are my references, and thank you all for your patient listening.
Thank you, Dr. Oshajov, for a wonderful presentation. This indeed
Thank
is
you,
a very rare case, although yes, coming to the point about immune status of the patient. Can you tell me, besides HIV positivity, any other conditions of immunocompromisation which can lead to a plasmablastic lymphoma?
Epstein-Barr virus infection.
No, Epstein-Barr virus is a co-infection along with HIV usually, or any immunocompromised state, which is positive usually in 50% and more cases of plasmablastic lymphoma. That's okay. Any other cases of causes?
Use of immunosuppressant drugs.
Yes. Any others?
So diabetes.
Diabetes. Any autoimmune conditions? Have you heard of a condition or a phenomenon called immunosenescence?
I've heard the term, but I'm not very sure about it.
Okay. From the term immunosenescence, can you make out what is happening? Senescence, obviously, aging of the immune cells. So, what might happen?
Sir, apoptosis may be defective. Apoptosis of the cells.
Yes. So you might get defective immune status in usually persons above 60 years of age. That is one of the causes of plasmablastic lymphoma also. Thank you, Taruk.
Yes.
Handing over to you.
Very nice case. I must congratulate you. Now, I would like to know what was the HP diagnosis in this case?
Sir, HP diagnosis, we suspected it to be a malignant lymphoid neoplasm.
Of high-grade lymphoma, low-grade lymphoma, what
Yeah,
kind of?
High grade, sir,
High grade.
Yeah.
What I wanted to know, what prompted you to pick up this panel?
Sir, the histopathological picture actually prompted us to take this panel.
Okay. Did you examine the peripheral blood smear in this case?
No, sir.
Do you think it is important?
Yes.
Did you examine the lung mass? Did you have any FNAC or
The patient
CT-guided biopsy of the lung mass?
came with the MD CT, so no biopsy was performed from the lung mass.
Okay. Did you perform bone marrow examination?
Bone marrow examination has been suggested, and the reports have not come yet.
And, do you think that it is important in this case, bone marrow examination?
Bone marrow examination to rule out plasma cell neoplasm.
Yes, very important to rule out any other plasma cell neoplasm. Bone marrow examination must have been done in this case before putting it as a complete case report. What are the differential diagnoses in this case of this plasmablastic lymphoma?
Lymphoplasmacytic lymphoma, immunoblastic DLBCL, primary fusion lymphoma, ALK positive DLBCL. These were our differential diagnoses.
Okay, thank you. Thank you very much.
Thank you, sir.
Neha, please unmute.
Yeah.
Good afternoon to all of my respected teachers and fellow colleagues. Myself, Dr. Poulami Vishwas, second year PGT, Department of Pathology in NRS Medical College and Hospital. Today, I am going to discuss three rare fungal infection in lower extremity, a diagnostic challenge. I have done this study under guidance of Associate Professor Dr. Moumita Maiti in our very own pathology department. As we all know, locally invasive fungal infections contribute substantial morbidity and mortality in immunocompromised and diabetic individuals. The incidence of this infection are increasing in number due to increased number of this type of patients. Here I am presenting three rare fungal infections in lower extremity. In my first case, 56-year-old male laborer presented with left foot swelling for last 2 years. His keto-weighted MRI shows a SOL involving dorsal and plantar aspect of foot extending through the intermetatarsal spaces with cortical erosion. His PET CT shows a large heterogeneous FDG habit infiltrative lesion seen in left foot involving both dorsal and plantar aspects. His HP shows sulfur granules containing fungal hyphae surrounded by mixed inflammatory cell infiltration and foreign body giant cell reaction. Fungal hyphae are highlighted by pus stain. Figure 1b, we can show this. Though radiological features suggestive of sarcoma, HP shows feature consistent with 2 mycetoma. In our second case, 65-year-old elderly male farmer presented with right ankle lesion as a verrucous nodule and non-healing ulcer for last 1.5 years. His HP shows pseudoepitheliomatous hyperplasia, pigmented fungal sclerotic bodies, dark brown thin walled ovoid to spheric spores resembling copper pennies, feature consistent with chromoblastomycosis. In my third case, 58-year-old male diabetic male presented with ulcerofungating exophytic growth on lateral aspect of right leg. His HP shows globular cyst representing sporangia in different stages of development with Swiss appearance, surrounding dense mixed inflammatory infiltrate with lymphocyte and histiocyte. Leukocytoma and chromoblastomycosis generally affect lower extremity due to traumatic inoculation of fungi into the skin. But here the patient diagnosed as leukocytoma presented with only foot swelling without any discharging sinus, and his radiological features mimic as sarcoma. Cutaneous chromoblastomycosis is chronic cutaneous mycotic infection due to dematiceless fungi such as Fonsesia pedrosi, Fonsesia compacta, etc. It generally mimic leprosy, mycetoma, cutaneous tuberculosis, dermal leishmaniasis, etc., which differentiated by histopathologically the triad of pseudo epitheliomatous hyperplasia, neutrophilic infiltration with microabscess formation, and hallmark sclerotic bodies. Rhinosporidiosis generally affect nasal mucosa, ocular, and genital mucosa. But here, in our patient, it affected lower extremity, which is very rare presentation. This type of atypical presentation may be confused with soft tissue tumor or papillomas. So, definite diagnosis of rhinosporidiosis by histopathological demonstration of sporangia and endospore is necessary. So, we can conclude that as these infections are local invasive without any systemic spread, so if we diagnose the cases properly with HP and spatial stain and initiate the treatment promptly, then we may achieve complete cure of the disease. Thank you for listening.
Thank you, Dr. Polomi. All these cases were excellent, very nicely worked cases, very clear-cut cases, no confusion in diagnosis. But I know very little of mycology. I have one query regarding the first case. The first case, you have mentioned that PET CT was done. Why PET CT was done?
Sir, the surgeon, the concerned surgeon suspect this is a case of sarcoma. That's why PET CT was done.
Okay. Was there any FNAC done in that case?
No, sir. We received we received the 3 cases as biopsy sample.
That mass, when they suspected sarcoma, and they did this PET CT, but they did not perform any FNAC.
No, sir.
Okay. Next question. Was any culture done, fungal culture?
No, but we asked for further fungal culture from fish sample.
Okay. In the third case, that was a case of rhinosporidiosis. The site was unusual, very unusual for a rhinosporidiosis. Did you follow the patient for any systemic involvement of rhinosporidiosis?
Yes, sir, we are following the patient. We have tried to follow the patient, but the patient lost to follow up, sir.
Okay. Banita, you continue.
Thank you, Tarok. You have asked some of the questions I was going to ask, so the time will be saved. So I wanted to know what are, besides this type of presentation of chromoblastomycosis, any other type of presentation which may mimic some other disease?
Sir, chromoblastomycosis can be confused with North American blastomycosis. Yes, sir, that's it.
Okay. Some disease which is endemic in the eastern part of India that might be clinically confused with that particular.
Squamous cell cancer, it can be confused with squamous cell cancer?
No. Where it involves the lymphatic vessels.
Okay, it's elephantiasis, sir.
Yes. Good. Okay. Thank you for a nice presentation.
Thank you so much, sir.
Thank you, judges. Thank you, Polomi, for your wonderful presentation. Now, moving on to our last presentation of e-poster is by Dr. Riya Das. She is PGT from Department of Pathology in KPC Medical College and Hospital. Her topic is a case of xanthogranulomatous mastitis masquerading as malignant breast lesion, creating diagnostic dilemma. Dr. Riya?
Hello, am I audible?
Yeah, you're audible. Please share your screen.
Is my poster visible?
Yeah, it's visible.
Good afternoon, respected judges, teachers, and the dear delegates. I am Dr. Riya Das, and I'll be presenting on a case of xanthogranulomatous mastitis masquerading as a malignant breast lesion, creating a diagnostic dilemma. I have studied this case under the guidance of Dr. Pratyusha Bhattacharjee, Dr. Papia Majumdar, Dr. Devashish Guha, and Dr. K.A. Basu in the Department of Pathology, KPC Medical College and Hospital, Jadavpur. So to begin with, my case was basically a 65-year-old lady who came in with a complaint of lump in the right breast for past 3 months. On examination, we found that there was an irregular, ill-defined hard lump in the upper inner quadrant of right breast, which measured around 3 centimeter into 3 centimeter and was associated with a retracted nipple. Then USG studies, it was revealed that the lesion was suspicious of malignancy indicated by a score of query Biret-SCAT 4, along with presence of regional lymph nodes in the right axilla. So as usual, we proceeded on to doing an FNSC, which was then followed by an excisional biopsy. We were really expecting to find some malignant cells in the smear, but to our surprise, we actually found that there were clusters, few aggregates of histiocytic cells along with plump macrophages in a necroinflammatory background. So for confirmation, we then did a ZN preparation, and there we could not demonstrate any AFP. Finally, in histopathological examination, we saw that there was presence of dilated ducts having detritus. Those were rich in macrophages, along with a periductal florid inflammatory reaction, again rich in foamy histiocytes, multinucleated giant cells, plasma cells, and few lymphocytes. So we can see that we could reach to the final diagnosis of xanthogranulomatous mastitis only after a proper histopathological evaluation. Now, xanthogranulomatous mastitis is a rare breast pathology which is benign in nature and is commonly presented by females in their second and seventh decade. It can happen due to two causes. Firstly, it can happen due to rupture of a dilated duct or any cystic structures, or following a direct trauma to the breast. The most important point that we have to keep in mind while examining a case of xanthogranulomatous mastitis is its presentation, because this lesion most often clinically and radiologically, it resembles a invasive breast carcinoma. Many studies have been performed. One of the first cases of xanthogranulomatous mastitis was demonstrated by Shin et al. In the year 2005. Then again in the year 2009, Ku and Zhang studied 16 cases of xanthogranulomatous mastitis, where they came to the inference that it is possibly caused due to rupture of a dilated duct. They also concluded that the major inflammatory cells involved were multinucleated giant cells, macrophages, and plasma cells. Another study, they demonstrated that any xanthogranulomatous inflammation is associated with obstruction of dilated ducts, presence of hemorrhage, lymphocytes, as well as presence of polymorphonuclear leukocytosis and replacement by xanthoma cells. A study by R. Heer et al. Concluded that for reaching the absolute diagnosis of xanthogranulomatous mastitis, an FNA study along with a histopathological evaluation is an absolute mandate. There were many other studies which focused on the clinical presentation. One such study was by Bomanikar et al. In the year 2017, where they demonstrated that sometimes the xanthogranulomatous mastitis is also accompanied with abscess formation and mass formation. That is how they actually resemble an advanced tumor. So to finally conclude, I will say that this was such a thought-provoking case where the lesion initially resembled that of a breast carcinoma. Then again on FNSE, the diagnosis tipped towards tuberculous mastitis, which was eventually ruled out. And then finally, only with a histopathological examination, we could reach a conclusive diagnosis, and ultimately we could help the clinician in deciding the necessary treatment for the patient. Thank you. These are my references.
Thank you, Dr. Ria.
Thank you.
For a well-presented poster. You have shown epithelioid cells in the FNSE, right?
Yes, sir.
But when you're showing the histopathology, you're not showing any epithelioid cell granulomas.
No, sir, because in
why not?
So because in histopathology sections, we did not find any granuloma. So, and because in FNSE, there was a presence of granuloma. So for ruling out even the final possibility, we did ZN stain preparation on both FNSE as well as histopathology.
Actually, by definition, xanthogranuloma on cytology should not show any epithelioid cells.
Yes,
it should show only xanthoma cells or vacuolated macrophages. That is one thing, one discrepancy I found. And another thing, why didn't you consider diagnosis of duct ectasia in this case?
So because duct ectasia was not present.
You said there was dilated ducts.
Oh, sorry, sir. There was dilated ducts and presence of
which contained
detritus. Yes, sir.
detritus, which is what is seen in duct ectasia.
So
you said plasma cell. There was florid infiltrate comprising plasma cells, lymphocytes surrounding the ducts. All of these are features of duct ectasia.
Of duct ectasia, yes, sir.
Yes. So why didn't you consider a diagnosis of duct ectasia? Why did you? This is very rare. In fact, quite doubtful. In fact, in fact, the Korean article which you have quoted, they are also pretty iffy about this particular condition. I went through the article, which actually this entity itself is a very dicey one. So why didn't you consider duct ectasia?
So actually there was lots of macrophage infiltration. So we tipped the diagnosis, actually we went more in favor of xanthogranulomatous inflammation.
Okay, thank you. Tarok, over to you.
Very presentation, but I have similar doubt as Banik the raised. What the FNAC image have shown, the FNA image you have mentioned that shows a epithelial granuloma.
Yes,
I
sir.
strongly doubt whether it is a granuloma or not. What are the mimickers of epithelioid cells?
So mimickers
on
of
FNA?
mimickers of epithelioid cells are few histiocytes can appear as epithelioid cells. Histiocytic cells can appear as epithelioid cells.
Anything else?
Other than that, so I cannot think of one right now.
This picture which you have mentioned, I think it is a capillary spindle cell, capillary blood vessel. That is why it is showing a ribbon-like appearance. It is not a granuloma. That's why you have not found any granuloma on the biopsy also.
Okay, sir.
So that, taking nothing away from you, it is a case of chronic periductal mastitis, and there is a collection of foamy histiocytes. All these things are there. So what are the causes of granulomatous mastitis? You have mentioned that it was reported as granulomatous mastitis in the FNA report. What are the causes of granulomatous mastitis?
So generally, a granulomatous mastitis, it is actually idiopathic, sir. But then again, it can happen following a rupture of a dilated duct or any cystic structure, or by direct trauma caused to the breast.
Okay. Any autoimmune disease can cause?
So yes, IgG4 nephropathy can cause a xanthogranulomatous inflammation.
What is the chance of getting AAB positive and tuberculosis in case of breast?
So tuberculous mastitis in India, it is actually less than 3%.
Very
Incidence
rare.
is less
Very
than
rare.
3%.
So even if you diagnose granulomatous mastitis, you have mentioned that you were thinking of tuberculosis. It is very rare. Even if you diagnose granulomatous mastitis, the causes are anything other than tuberculosis. Okay, that's it. Thank you. Thank you very much.
Thank you, sir.
Thank you, judges. Thank you, Dr. Ria, for your wonderful presentation.
Thank
so
you.
Now we are over with our e-poster session. I would like to thank all our respected judges for their valuable time and patient listening. And also I want to give heartfelt thanks to all our presenters for their enlightening presentations. So now we'll move to our next academic session on free papers. Before that, let me introduce to our chairperson, Dr. Bhavna Bhutoria ma'am. She is the professor in the Department of Rampurhat Pathology in Rampurhat Government Medical College, Birbhum. And so before we start with our free paper session, I'll guide you with the basic rules for presentation. All presenters should have their good broadband connection, and presenters are requested to keep their camera off and mic muted while not presenting. Total duration for presentation is 8 minutes. There will be reminder at 6 minutes, and the last 1 minute will be there for questioning. And also, I request all the delegates to put their question on the chat box. I'll take the question personally on the chat box. Thank you. So I first call our first presenter, Dr. Bindu Jadeja. She's second-year resident in microbiology in GMERS Medical College, Gandhinagar. Her topic is seroprevalence of chikungunya in tertiary care hospital, Gandhinagar. Dr. Bindu, are you ready? Dr. Bindu, can you hear me? Bhavna ma'am, what should we do? Shall we move on to next?
So, Dr. Bindu Jadeja, are you there? If we have no response from this presenter, let us move on to the next person.
Okay, ma'am. Sure, ma'am. So our next presenter is Dr. Jagrut Udeshi. Dr. Jagrut, are you there?
Yes, ma'am. Can you hear me?
Yes, I can hear you. Okay. So Jagrut, is your topic is P16 expression in oral squamous cell carcinoma and its variants. Dr. Jagrut, please share your screen.
I think my video is not very clearly visible. Is it fine? This much?
We can see.
Or we can. Oh, thank you. I'll share my screen. This, just a second. I'm sharing my screen. Just a second, ma'am. Is it visible? Can you hear me?
Yeah, I can hear you, but
It's not visible.
Not visible.
Just a second, ma'am. I'm trying to. I'm getting all the folders, but this PowerPoint presentation is only not coming.
Dr. Jagrut, are you using a laptop?
Yes, yes, madam.
First, you can open your PPT, minimize it, and then go to the share option.
Yes, I have done that same thing, but
open that.
Is it open now?
No, still not open. You just click the same.
You can see your folders, but you have not. Your PPT is not visible.
Okay, I have shared my whole PPT, and it's in PowerPoint mode only now.
So you open it and then share the whole screen or the window.
Okay, I'll share it once again. It's visible now?
Yeah. Yes. All right.
Okay. I can minimize this videos anywhere it's coming in between. Okay. 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 So I will be presenting a paper on P16 expression in oral squamous cell carcinoma and its variants. So coming to introduction, oral squamous cell carcinoma is most common cancer in men and third most common cancer in women. Present study is an attempt to study the association of HPV in oral squamous cell carcinoma by using P16 immunostaining. P16 positivity correlates with differentiation and is considered as a prognostic factor as per various studies. So my study design was time bound and it was retrospective and prospective study. And study period was of 2 years from October 2019 till September 2021, and institutional ethical committee clearance was obtained. So my inclusion criteria were histologically diagnosed oral squamous cell carcinoma during the study period at Pathology Department, KMC, Mangalore, Karnataka, and exclusion criteria was inadequate samples. IHC which I used was P16, and positive control for P16 I used was tonsils. Here, the intensity of staining in IHC was graded as 0 as negative, 1 plus for focal, that is 1 to 50% of cells were showing positivity, and diffuse was given as 2 plus if more than 50% cells were showing positivity. So here, coming to results, in well-differentiated oral squamous cell carcinoma, 26 cases showed no reactivity, whereas 10 cases showed focal and 7 cases showed diffuse positivity. In moderately differentiated carcinoma, 20 cases didn't show any reactivity, whereas 3 cases show focal and 3 cases showed diffuse. Whereas in poorly differentiated carcinoma, oral squamous cell carcinoma, 1 case showed no reactivity and 1 showed focal positivity, about 10%. So these are the figures. It is showing P16 IHC positivity. Here in first case, you can see the diffuse staining of the squamous cell carcinoma cells. Okay, here we can see both cytoplasmic and nuclear block positivity here. Whereas in the second figure, we can see the focal staining of the cells. Only few cells showed positivity here. So this was first was given as +2 scoring, and the second one was given as +1 scoring. So coming to discussion, identification of the events relevant to the malignant transformation is of the utmost importance. It can be useful for the clinician to evaluate the progression risk of pre-malignant lesion towards cancer, and preventive strategies can be performed. Therefore, in the current study, we attempted to evaluate the expression of P16 in oral squamous cell carcinoma. The progression of cells from G1 to S phase is blocked by protein P16. P16 is a protein, a CDK inhibitor, which inactivates cyclin D CDK4/6 complexes and subsequent blockage of retinoblastoma protein, PRB. Inactivation of this PRB by phosphorylation causes P16 expression. See here, a P16 IHC is a technically simple and widely available test, and as an adjunctive test also can provide useful information about the role of this marker in carcinogenesis. Evaluation of P16 expression by immunohistochemistry has been the focus of several studies on human precancerous and cancerous lesions. Decreased expression of P16 and overexpression of in head and neck squamous cell carcinomas has been shown in various studies. In the present study, we attempted to evaluate P16 expression in squamous cell carcinomas of the oral cavity. The present study consisted of 71 cases of oral squamous cell carcinoma. Here we encountered 17 cases out of 43 positive in well-differentiated squamous cell carcinoma, 6 positive cases out of 26 in moderately differentiated squamous cell carcinoma, and 1 out of 2 positive in poorly differentiated squamous cell carcinoma. So here, coming to the conclusion, P16 positivity correlates well with the differentiation of oral squamous cell carcinoma and suggests good prognostic value. These are my references. Thank you.
Dr. Douglas,
Yes, ma'am.
it was a good presentation, very clear.
Judge. Here the chairperson, no judge.
So
Very good presentation.
it's a very good presentation, and I think you have cleared everything. All concepts are clear, but I just want to ask you one thing. What was the significance of this study? Like why do we do this study? Do we suggest something to the clinician by doing this?
If it is, shows P16 positivity, it has good prognostic value, ma'am.
That is why.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am. Yes, ma'am.
Is there any therapeutic value with P16? If you P16 positive, is there any therapeutic value?
Dr. Douglas, you're there?
Yes, ma'am.
Can you listen to the question?
Yes, ma'am.
Is there any therapeutic value? Prognostic value is there.
Therapeutic.
Nowadays targeted therapies are available. and
Yes.
the radiotherapy people can give. So there is therapeutic value also.
Yes, ma'am. I'm very not very clear about it, but I'll just read it once again.
We also don't know what is the drug they are using, but there is some therapeutic value also.
Yes, ma'am.
Okay, next. Thank you.
Thank you. Thank you, Mamta ma'am. Thank you, Bhavna ma'am. Now moving on to our next presenter, Dr. Renu Rathore. She is from Jhalawar Medical College, Jhalawar. Her topic is histomorphological spectrum of lichenoid tissue reaction, a tertiary case study. Dr. Renu,
Yes,
are you ready?
Yes, ma'am.
Okay.
Ma'am, I'm audible.
Yeah, you're audible.
But we can't see.
Okay,
Your video is off, Renu.
ma'am, shall I start?
Your video is off.
Video is off.
Yeah. Can you do it on? Like, go to the participant one and do your. There is red. Yeah, we can see it right. Yeah.
Okay.
Share your screen.
Yes, ma'am. Okay, ma'am. Good afternoon, ma'am. My topic is histomorphological spectrum of lichenoid tissue reactions, a tertiary care study. Introduction is.
Dr. Renu, you have to share your screen. Share your PPT on the screen, please.
Nothing is visible.
Sorry, ma'am. I'm trying.
Dr. Renu, please, yeah.
You
share your screen and your video also.
Video also. Please put on your video.
Okay.
Yes,
Now
yes,
is it?
Yes, but it is not visible clearly. Small. Picture is very, 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 very tiny. Your letters are very, very tiny. Can't be clearly. ভাবনা দেখতে পাচ্ছিস?
হ্যাঁ, make it a slideshow. Make it a slideshow.
ওই জন্য দেখ ছোট ছোট দেখাচ্ছি।
Dr. Renu, make it a slideshow.
Slideshow option is given in the top, Renu. You can see there. Just see animation.
Make it slideshow. এই যে এখানে আছে এর মধ্যে পাওয়া যাবে।
Dr. Renu, see in the home insert design animation slideshow. It's written there in the sequence. See in the top there is a row. Can you follow?
There is
in the lower bar also there is a slideshow option. Full screen option.
I can't see.
You can see your screen, Dr. Renu?
Yes, ma'am, I can see my screen.
So you just see there is a home button. You can see home.
Home button and in the home button there is slideshow.
I have shared the screen. Please continue.
Now start.
I have shared the screen. Please continue. Just tell me when to change.
Okay, sir.
Dr. Renu, I have already shared the screen. Just can start.
Yes.
Dr. Renu, you please start.
Okay, sir. Yes,
start.
You ask to change the slide after every slide. Okay? You ask next.
Okay, ma'am.
Thank
So, so my topic is histomorphological spectrum of lichenoid tissue reactions, a tertiary care study. So, yes, ma'am. So introduction is lichenoid tissue reaction is a histological pattern which is characterized by an epidermal basal cell damage that is intimately associated with the massive infiltration of mononuclear cells that hugs the dermoepidermal junction, except for subtle differences that define the particular variant. The prototype of all the lichenoid eruptions is lichen planus, and the basal cell death usually involves only scattered cells in the basal layer that become shrunken with eosinophilic cytoplasm. And these cells, which have been called civet bodies, they often contain pycnotic nuclear remnants. Vacuolar change, which is liquefactive degeneration, is often an integral part of the basal cell damage in the lichenoid reaction. It results from intracellular vacuole formation and edema, as well as from separation of lamina densa from the plasma membrane of basal cells. As a consequence of basal cell damage, there is variable melanin incontinence resulting from interference with melanin transfer from melanocytes to keratinocytes, as well as from the death of cells in the basal layer. Another feature of the lichenoid reaction pattern is a variable inflammatory cell infiltrate that varies in composition, density, and distribution according to the disease. So next slide, please. Yes. Other features that may be present are wedge-shaped hypergranulosis and Kasperi-Joseph spaces, sawtooth reteridges. These features are seen in lichen planus. Perifollicular infiltrate with follicular plugging, which will be seen in lichen planopilaris. Giant cells and dermal infiltrate, often clasped by acanthotic downgrowths, which will be seen in lichen nitidus. Purpura, like in lichenoid purpura. Satellite cell necrosis in graft versus host disease. Eccrine duct involvement in lichen striatus and keratosis lichenoides chronica. So a specific histological diagnosis can usually be made by attention to such factors like the nature and extent of basal damage, the nature, composition, and distribution of inflammatory reaction, the amount of melanin incontinence that results from the basal damage, the coexistence of another tissue reaction, and other individual characteristics. Next, sir. So this study was done to evaluate, to analyze the spectrum of histomorphological features of various lichenoid tissue reactions and to know the age and sex distribution of lichenoid tissue reactions. So next slide. Material and methods. All the patients who presented in our hospital with the lesions which were clinically diagnosed as lichenoid dermatosis, these were evaluated by punch biopsy, and the time duration was from June 2019 to June 2021. These cases were included in the study, and the biopsy specimen which were received were fixed in 10% formalin. They were processed and embedded in paraffin, and 3 to 4 micrometer thick sections were made, and these sections were stained with hematoxylin and eosin stain, and a total of 101 cases were analyzed and histopathological diagnosis was made. Out of these total 101 cases with clinical diagnosis of lichenoid dermatosis, 69 cases were histopathologically concordant with the clinical diagnosis, and 5 cases were diagnosed on histopathology only. So a total 74 cases were analyzed, and of these total 74 histopathologically diagnosed cases, the most common pathology which was observed was lichen planus and its variant, which was 57 cases out of 74, making it up to 77.03% of all the cases. And these findings are compatible with the study by Mukesh Kumar et al. Also. And out of lichen planus cases, the most common was classical lichen planus. It was most common pathology, 37 out of 74 cases, approximately 50%, followed by lichen planus pigmentosus, hypertrophic lichen planus, follicular and oral lichen planus, which were two cases each, and atrophic and genital lichen planus, one case each of these. This table is showing distribution of cases of lichen dermatosis. So lichen planus and its variants were 57 cases, 3 cases of erythema multiforme, 3 cases of lichen sclerosis at atrophicus, 2 cases of pityriasis lichenoides chronicus, 2 cases of drug eruptions, 2 cases of maculopapular amyloidosis, 1 case of polymorphic light one case of bullous lupus erythematosus, 1 case of pigmented purpuric dermatosis, 1 case of poikiloderma, and 1 case of lichen nitidus was also there. So next slide, please.
Next slide.
Sir, next slide, please. So, yes, among the distribution of cases, as we discussed, lichen planus and its variants were the most common. Among these, 37 cases were of classical lichen planus, and 9 cases were lichen planus pigmentosus. Hypertrophic lichen planus was 5 cases, 2 cases of follicular lichen planus, 2 cases of oval lichen planus, 1 case of atrophic lichen planus, and 1 case of genital lichen planus was seen. And this is the percentage of all the cases. The histopathological features were studied. These features were epidermal changes and dermal changes, and basal layer vacuolation, band-like inflammatory infiltrate, and melanin continence. So these 3 features were seen in most of the cases. And the most common histopathological feature which was observed was liquefactive degeneration of basal cell layer. It was seen in 70 out of 74 of cases, that is 94.6% of cases, the liquefactive degeneration was seen. And a band-like inflammatory cell infiltrate was seen in 68 of the cases, and pigment incontinence was seen in 35 of the cases. So these 3 were the most common features which were seen in histopathology. Other features which were seen were perivascular lymphocytic infiltration in the dermis. It was also observed in 51 of the cases. Sawtooth rete ridges were seen in approximately 27 cases. Civet bodies were seen in 21 cases. And other features like acanthosis and spongiosis, parakeratosis, and hyperkeratosis were also seen invariably. So next slide, please. So this is the table which is showing histopathological feature epidermal changes. So the epidermal changes which were seen were liquefactive degeneration of basal cell layer in 94.6% of cases. Then spongiosis was seen in 41.9% of cases. Sawtooth rete ridges in 36.5% of cases. Acanthosis in 32.4% of cases. Hyperkeratosis in 31.1% of cases. Civet bodies were seen in 28.4% of cases, and parakeratosis in 17.6% of cases. In this images, we can see the first one is of the case of lichen planus hypertrophicus. So we can see there
Dr. Renu, your time is over.
Okay.
You can continue.
So later to finish.
Yeah.
Please continue. Please continue.
Continue.
Yes, in this image, in these images, we can see there's hypergranulosis, acanthosis, and hyperkeratosis is also seen. And there was a band-like infiltration also at dermoepidermal junction. In this another case, we can see there is a massive infiltration of lymphohistiocytic cells at dermoepidermal junction, which is obscuring the junction, and there was also basal cell damage. So the basal cell layer is also not visible here. And melanin incontinence was also present. So these were the features which were studied in histopathology. The dermal changes which were seen were band-like inflammatory infiltrate, melanin incontinence, and variably eosinophils and plasma cells were also seen, but mostly it was lymphocytes in most of the cases. So in my results, the age group which was most frequently affected was 41 to 50 years of age. Females were more commonly affected than males in all the age group, and the male to female ratio was 0.45 to 1, and these were also consistent with other. In this table, we can see the age-wise distribution of cases, and most common was in 41 to 50 year, 21 cases were seen. And in every age group, females were the predominant, females were affected most commonly. 68.9% of cases were females. So conclusion is lichen planus is the most common lichenoid eruption and the classical lichen planus is most common of all the lichen planus and variants. And on histopathology, most frequent findings are epidermal basal layer liquefactive degeneration, followed by band-like inflammatory infiltrated dermoepidermal junction and melanin pigment incontinence. And these are seen in all age group, but there's slight predominance in 41 to 50 years of age group in our study. There's female predominance with a male to female ratio of 0.45 to 1. And it is important to differentiate lichen planus from other lichenoid tissue reactions from both treatment and prognostic point of view. And they are a fairly common type of dermatosis, and histopathology is the gold standard to approach and confirm the specific diagnosis for timely management and reduction of morbidity, which is involved in chronic cases. Thank you, ma'am.
Thank you, Dr. Renu, for a good presentation, but your presentation was very much cramped up and because their slides were so busy. It makes only 3 to 4 lines per slide and always give up a little. I think we cannot take more questions because we are already
time
past the
crunch.
time.
Okay, ma'am. Okay, ma'am.
Let us move to the next.
Thank you, Dr. Renu. Now moving on to our next presenter is Dr. Sanjay Kumar Singh. He is a PGT.
Audible?
He is a PGT from Pravara Rural Hospital, Rahatal, Loni, Ahmednagar. A rare case of, he is presenting a rare case of non-Hodgkin lymphoma in breast. Yes, you are audible, Dr. Sanjay. Please proceed and share your screen.
I'm visible also, ma'am.
Yes, you are visible.
Ma'am, I'm sharing my screen.
Yes.
Good evening, ma'am.
Yes.
Ma'am, actually, I've made a poster on that, a rare case report of non-Hodgkin lymphoma in breast. So breast lymphomas are either primary or secondary, that it is a rare disease. Primary breast lymphoma has got an incidence of 0.04 to 0.5%. Yes, ma'am. Ma'am, audible? Hello, ma'am. Ma'am, I'm audible?
To continue.
Yes, ma'am.
You continue, Sanjay. Please continue.
Yes, ma'am. Ma'am, it is a case report of a 48-year-old female presented with a mass in right breast since 2 months. On examination, a 2 into 2 centimeter lump is palpated in right breast in upper outer quadrant. On USG, they have given a 17 into 27 into 3 mm lesion is seen at 9 o'clock position in the right breast, suggestive of fibroadenoma Barrett 4B. The axillary lymph node were enlarged. True cut biopsy was performed and reported as positive for malignancy. Modified radical mastectomy was performed along with axillary lymph node dissection. Lesions reveal polymorphous population of atypical lymphoid cell infiltrating into the best parenchyma, sparing the normal duct and terminal duct unit. Ductal arrangement is also noted. Atypical lymphoid cell predominantly show medium to large cell having a scanty cytoplasm, high NC ratio, oval intent nuclei with fine chromatin. Some occasional cells show central prominent nuclei. Background show lymphocyte, centrocyte, plasma cell, and few mast cell. Binuclear and multinuclear cell are also seen. Increased mitosis is seen. Adjacent breast parenchyma show a focus of atypical ductal hyperplasia along with normal TDUL and extralobular unit. Base is free and 0.3 centimeter away from tumor. The nipple areola appear normal. Adjacent breast parenchyma show normal TDLO and duct. Section from the axillary lymph node show complete effacement of the architecture with obliteration of the subcapsular sinus And it shows sheet of medium to large cells showing centroblast, immunoblast along with lymphocyte. And then we have done a ISC on the section. So the atypical cells were positive for CD20, MUM1, BCL6, and BCL2, while they were negative for CD3, CD5, CD10, and CMYC. MIB1 proliferation index was 95%. Hence, final diagnosis of non-Hodgkin lymphoma, diffuse large B cell type was given. And these are the images. I mean, two-cut biopsy, the picture that we were giving was positive for malignancy, suggestive of IDC. But in after MRM, what we got is non-Hodgkin lymphoma in breast. Discussion. Primary breast lymphoma is defined pathologically as presence of lymphomatous infiltrate in normal breast tissue in a patient with neither previous nor concurrent non-Hodgkin lymphoma at another site. Although involvement of ipsilateral axillary lymph node enlargement may be present, it is a rare tumor and often present as innocuous lump. Primary breast lymphoma shows a wide range age distribution with bimodal peak, with younger population showing bilateral involvement and older population showing unilateral involvement. The majority of breast lymphoma are of the non-Hodgkin lymphoma type. It usually affects women in their 5th or 6th decade of life. The most common of primary breast lymphoma is a palpable lump. Less frequently, it may present as diffuse breast enlargement. There is usually unilateral involvement, but bilateral cases have also been reported. All histological type of lymphoma has been described. Primary breast lymphoma are most commonly B cell lymphomas. Approximately 1/2 are diffuse large B cell lymphoma. Pathology remain the gold standard to differentiate these two malignancies. Histopathology, ISC or flow cytometry help. The diagnosis of primary breast lymphoma must always be confirmed by histopathology and immunohistochemistry. And these are the references that I have taken, ma'am. Hello, ma'am.
Dr. Sanjay? Thank
Yes,
you
ma'am.
for the interesting case presentation.
Thank you, ma'am.
Did you exclude those widespread, whether it was a widespread disease or not, by doing bone marrow examination and CT scan of the chest abdomen? Did you exclude the widespread?
Ma'am, actually, bone marrow examination. Ma'am, actually, in this case, bone marrow examination was not done, ma'am. There were lymphadenopathy, peripheral lymphadenopathy was there, ma'am. Actually, ma'am, FNAC was also not done properly, ma'am. After true cut biopsy, it was showing a positivity for malignancy. In true cut biopsy, it was not sure that whether it is IDC or any other thing. Then after MRM, it was proved that it is a non-Hodgkin lymphoma. So it should be before MRM. That what I feel.
Oh, I was saying, like you are calling it as a primary breast lymphoma. So what is the criteria for primary breast lymphoma? You call it a primary lymphoma. There is a criteria. What is the criteria? So in that
I don't
criteria,
know.
you have to exclude whether widespread involvement is there or not. Okay, thank you for the presentation. We can move on to the next case.
Okay, ma'am. Thank you, Dr. Sanjay Kumar Singh.
Thank you,
May I
ma'am.
ask the delegates to mute their audio, please? Delegates, yeah. Now we are moving on to our next presentation. Dr. Utsav Das will present his next presentation. He is from third year PGT from CNNC Medical College and Hospital. His topic is the IHC expression of Ki-67 in colorectal carcinoma and correlation with clinicopathological correlation, clinicopathological factors. Dr. Utsav, are you there? Yeah, you're there. Dr. Utsav, please
Yes,
share
I'm
your
there.
screen.
Can you hear me?
Yeah, I can hear you.
Yeah.
Your audio or video is not visible.
Utsav, congratulations for
Hi, ma'am.
song. Congratulations for song. Thank you.
Thank you, ma'am. Thank you, ma'am.
Mamata madam, start.
Then we can't see. Utsav, can you share your video, please?
Share code.
Dr. Utsav, please share your video.
Utsav. এই যে উৎসব কোথায় গেলি উৎসব?
Dr. Utsav, please share your video. Yeah, you have. Yeah, share your screen.
এই তো উৎসব স্টার্ট
Can't see it.
আমি
Okay, then
মানে
start. 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 You are audible. Start.
কোথায় গেল উৎসব?
উৎসবকে আমরা দেখতে পাচ্ছি না ম্যাডাম, কিন্তু শুনতে পাচ্ছি।
কোথায় উৎসব? তোকে দেখতে পাচ্ছি না।
নেটওয়ার্ক প্রবলেম হচ্ছে মনে হচ্ছে।
হ্যাঁ উৎসব,
হ্যাঁ নেটওয়ার্ক প্রবলেম আছে, তাহলে শুধু স্টার্ট করে দিই।
এত ভালো গান গাইলি আর তোকে কেউ লোকে দেখতে পাবে না, এটা হয়? ঠিক আছে উৎসব স্টার্ট কর।
স্টার্ট করো।
কেউ করছে না।
ডক্টর উৎসব, ইউ স্টার্ট।
এত ইন্তু আর ও পারছে না, ও দুদিন বাদে পরীক্ষা।
ম্যাম আই থিঙ্ক ডিভাইসটা হ্যাং হয়ে গেছে।
তাহলে let us go to the next person, ma'am.
Ma'am, can we go to the move on to the next person, ma'am?
Yeah, move on to the next person.
Dr. Utsav, please join us next time. After
Next
some
time,
time. After some time. Yeah. Now I request Dr. Vibha Ravi Kumara.
Yes,
He's
ma'am.
a PGT in Department of Pathology from Kasturba Medical College, Mangalore. Her topic is histological analysis of malignant peripheral nerve sheath tumors in a tertiary care center in South India.
But
Dr.
Utsav, আচ্ছা
Dr. Vibha?
Yes, ma'am. Is my screen visible?
Ma'am.
হ্যাঁ, ওই যে উৎসব has come.
Ma'am, okay, shall we continue with Utsav?
Yes.
No, I think Vibha has started sharing her screen. Let us continue.
Utsav already shared screen. Utsav?
হ্যাঁ ম্যাম,
are you audible?
শেয়ার করেছি। হ্যাঁ শেয়ার করেছি। Yes ma'am, yes ma'am.
হ্যাঁ কর।
Okay.
Yes ma'am. স্টার্ট করব?
Yes.
Okay, let us continue. Continue with Dr. Utsav Das. Continue, Utsav.
Okay. Good morning, everyone. Today
Good
my
morning,
topic
good
is
evening.
the immunohistochemical. Oh yes, ma'am. Good evening. Today my topic is immunohistochemical expression of Ki67 in colorectal carcinoma and its correlation with clinico-pathological factors. The introduction. Well, nowadays there is a rising burden of colorectal cancer cases in India due to mainly the economic progress and change of lifestyle. So there is a increased burden of the cases. The Ki67 is associated with proliferative activation in. হ্যাঁ দেখা যাচ্ছে?
সব স্লাইড শো করো, স্লাইড শো।
ও স্লাইড শো দেখা যাচ্ছে না? ও এক সেকেন্ড। এবার আসছে? হ্যালো এবার?
No, we
এবার
can't
আসছে?
see the slides. No.
No.
আমি এখানে শেয়ার করে মানে করে দিয়েছি, স্লাইড শো ফরম্যাট করে দিয়েছি।
Slide show করে share the whole screen.
হ্যাঁ
share the whole screen করতে হবে।
হ্যাঁ আমি করে দিয়েছি, কিন্তু এখানে কোনো কারণে।
Okay, get out of that slide show. Get out of that.
ওকে চলে এলাম। হ্যাঁ বেরিয়ে এসেছি। হ্যাঁ
আবার শেয়ার
বেরিয়ে
করো।
এসেছি। আবার নতুন করে করব? আচ্ছা
হ্যাঁ আনশেয়ার করে আবার শেয়ার করো।
আচ্ছা এবার আসছে?
আগে স্টপ শেয়ারিং করো, করে আরেকবার করো।
ও আচ্ছা ওকে।
উৎসব কত ভালো গান গাইলি সকালবেলা।
থ্যাংক ইউ ম্যাম।
Okay, you continue in this format.
আচ্ছা এতেই কর। কন্টিনিউ কর, এতেই কর। এখানে হ্যাঁ দেখা যাচ্ছে। বাস এই পাতাটা পড়া হয়ে গেছে, পরের পাতা চল। হ্যাঁ এটা হয়ে গেছে, পরেরটা চল। হ্যাঁ
Continue. Move to next slide.
Acha. The objectives of my study was to study the clinico-pathological findings and to correlate between the histological grade, tumor stage, and Ki67 expression in the cases. The materials and methods. First, the grossing and histopathological examination of the colectomy specimens in our college was done, and then immunohistochemical staining of the histologically diagnosed cases with Ki67 marker was done. The result showed out of the 18 cases taken in this particular paper, 9 of them were male and 9 were female. The age of the patients ranged from 27 to 85 years, and maximum number of cases were from 4th decade. The common clinical presentation with which the patients presented were abdominal pain, altered bowel habit, and rectal bleeding. Out of all the cases, in histological grading, 2 cases were poorly differentiated, 8 of them were moderately differentiated, 6 were well differentiated, and 1 each from mucinous and signating special types. 10 of the cases showed regional lymph node metastasis. Then the Ki67 scoring was done, and Ki67 expression was found to be high in the colorectal carcinoma compared to the histologically normal tissues. No special relationship of Ki67 with location of the carcinoma was found, but there was a significant correlation of Ki67 scoring with histological differentiation. With increased histological differentiation, there was more Ki67. With poor differentiation, there was more Ki67 expression. This is the bar diagram showing the distribution of male and female population. This is the bar diagram showing the cases in different age groups. This is the pie chart showing proportion of cases according to the histological grading. 8 of them moderately differentiated, 6 were well differentiated. This is the gross examination of colorectal carcinoma, one of the cases. This is the photomicrograph showing normal mucosa adjacent adenocarcinoma along with peritumoral lymphocytic infiltration. This photomicrograph shows infiltrating well-differentiated adenocarcinoma. This is one of the immunohistochemistry stains. The photomicrograph showing Ki67 positivity, which is 3+ in moderately differentiated adenocarcinoma. This is a chart I made showing the association of Ki67 score with the grade of colorectal carcinoma. In case of well differentiated, the total score was 0 in 1 case and 1+ in 5 cases. Moderately differentiated cases, 1 showed 1+ and 7 showed 2+. And the poorly differentiated cases showed 3+ staining. And mucinous carcinoma, which was in which had a poor cellular outcome, had 0 score, and signating carcinoma had 2 scores. Conclusion: in this study, total 18 cases were studied. Highest number of cases were in 4th decade. Distribution of cases among males and females were equal. Common clinical presentations were abdominal pain, altered bowel habit, and rectal bleeding.
1 minute is left.
Acha, okay, thank you. In the conclusion, the histologically 2 cases were poorly differentiated, which showed 3+ staining. 8 were moderately differentiated, 6 well differentiated, and 1 each from mucinous and signating type. 10 of the cases showed regional lymph node metastasis. And in this study overall, it was found that high Ki67 expression in colorectal carcinoma is associated with decreased tumor differentiation, thereby poorer prognosis. These are the references that I used. Thank you.
Okay, thank you.
For good presentation. Madam, since we are moving short of time, let us move to the next case. If someone has
Yes,
questions, they can write in the chat box.
Okay.
yes.
Okay.
Okay.
Thank you, ma'am.
Dr.
Thank you,
Utsav,
ma'am.
thank you so much. Now, again, I would
Nice
like to call.
presentation.
Thank you.
Good.
Now,
Thank
I'd
you, ma'am.
again like to
তোকে
call
প্রাইজ
Dr.
দেবো পরে
আচ্ছা ঠিক আছে
পিজিতে
আচ্ছা ঠিক আছে
Dr. Vibha Ravi Kumar. She's a TGT in Department of Pathology from Kasturba Medical College, Mangalore, Manipal Academy of Higher Education, Manipal. Her topic is histomorphological analysis of malignant peripheral nerve sheath tumor in a tertiary care center in South India. Dr. Vibha, you may
Yes,
start. Yeah, please share your screen and your video.
Ma'am, is my screen visible?
Yes.
Okay, good evening, everyone. My topic of paper presentation is histomorphological analysis of malignant peripheral nerve sheath tumors in a tertiary care center in South India. Malignant peripheral nerve sheath tumors are soft tissue neoplasms that arise from peripheral nerves and extraneural soft tissue and account for 3 to 5% of soft sarcomas. They can occur in pre-existing benign nerve sheath tumors or in neurofibromatosis type 1, or it can occur sporadically. The study design was a retrospective cohort. The study period was 5 years. Institutional ethical committee clearance was obtained. Inclusion criteria were all soft tissue sarcoma resection specimens, and exclusion criteria was bone and liposarcoma cases and inadequate samples. A total of 55 soft tissue sarcoma, and they were classified according to the 2020 WHO class and bone tumors. The cases were analyzed histomorph and appropriate IHC were applied accordingly. Cases that showed nuclear and cytoplasmic positivity were considered as MPNST. Of the 14 cases of MPNST, the predominant cases were male, commonly affected. The most common location was head and neck, and they located 36% cases were associated with neurofibroma. Coming to the results, morphologically, the pattern of arrangement of tumor predominantly showed a fascicular growth pattern with alternating hypo and hypercellular areas in 92.9% cases. Whirling and herringbone pattern was seen in 14% cases, and nests and sheaths were seen in 7% of cases. The individual tumor cells were spindled with buckled wavy nuclei, and blunt-ended nuclei were also seen along in 78.6% cases. Pleomorphism was noted in 50% of cases. A characteristic vascular pattern that was noted was hemangiopericytoma vessels with perivascular accentuation of tumor cells and herniation of tumor cells into the vascular lumen. The background predominantly showed collagen, and along with that, myxoid change was seen in 57.1% cases. The predominant inflammatory cell type was mast cells. According to the FNC LCC two-step grading scheme, low-grade tumors included 35.7% cases and high-grade tumors were 64.3% cases. On IHC, most cases, 92.8% cases showed focal weak nuclear and cytoplasmic S100 expression, and diffuse strong S100 expression was seen in epithelioid variant of MPNST. Figure A shows a case of MPNST in fascicles of alternating hypo and hypocellular areas. A higher magnification is seen in figure B, which shows spindle-shaped cells with irregular buckled wavy nuclei. Figure C shows us the hemangiopericytoma-like vessels with perivascular accentuation of tumor cells. Figure D shows us the herniation of tumor cells into the vascular lumen. Figure E shows us the focal weak nuclear and cytoplasmic S100 expression. And figure F shows us the diffuse strong expression in epithelioid MPNST. Discussion. MPNST diagnosis can be challenging due to its heterogeneous morphology. Microscopically, these are cellular tumors with wide range of growth patterns, like intersecting fascicles, alternating hypo and hypercellular areas, and streaming. Less common patterns include whorled, curlicue, or herringbone pattern. Our study showed predominantly a fascicular pattern with marbleization. Only 14% showed whirling or herringbone morphology. All cases in the current study were spindle-shaped with pleomorphism noted in 50% of cases. The nuclei were mostly buckled wavy and 78.6 showed blunt-ended nuclei. According to study done by Recchi et al., where 63 MPNST cases were studied. Maximum cases showed marbleization with a variety of patterns like sheets, nests, fibrosarcomatous patterns, and herringbone. Nuclear features in their study were spindle, double buckled, and pleomorphism. The current study showed nests and sheets of epithelioid cells with ample eosinophilic cytoplasm, which was similar to the study done by Ducartman et al., where 6 cases were epithelial cells in an organoid pattern of cellular growth. These features corresponded to the features of epithelioid variant of MPNST. All cases in this series showed a hemangiopericytoma-like vessels with perivascular accentuation of tumor cells and herniation of tumor cells into the vascular lumen. Carr et al. Study of 24 MPNST cases were also noted this subendothelial proliferation of tumor cells in the vessels with herniation of neoplastic cells. This feature was also noted by Recchi et al. Background showed collagenous and myxoid areas. The inflammatory cells most commonly noted in MPNSTs are mast cells, which was similar to the present study where 93% cases showed mast cell infiltration. Ahmad et al., MPNST shows lower mast cell count than its benign counterparts. The S100 expression in all cases were focal weak nuclear and cytoplasmic positivity, except one case of epithelioid MPNST, which showed diffuse strong expression. Most MPNST in the present study were high grade according to the FNC-LCC two-step grading scheme. Conclusion: MPNST are one of the most challenging soft tissue sarcomas to diagnose. They clinically behave aggressively, therefore diagnosis has therapeutic implications. Our results suggest that with careful morphological evaluation of tumor growth pattern, cell characteristics, along with vascular architecture background, supplemented by S100 immunohistochemistry, can help in the accurate diagnosis of MPNST. These are my references.
Thank you, Dr. Vibha, for an excellent presentation of a beautiful study.
Thank you, ma'am.
Does anybody have any question? You can write in the chat box. If there is no question, I just want to ask you one thing. Did you find any difference in the presentation, in the clinical presentation, between the NF1 positive and non-NF positive MPNST cases? Neurofibromatous and non-neurofibromatous cases. Clinical presentation, was there any difference? Site of presentation?
Ma'am, clinically, most of the neurofibroma associated cases had multiple neurofibromas in the all over the body over a course of period of time, and transformed from neurofibroma to MPNST over a period of years. And most of the cases were some cases were in the abdomen, and few cases were from the head and neck side. Other than that, I didn't find any other difference in clinical presentation, ma'am. Except for that, yes, ma'am.
Did you see that there is a difference that in the location, like neurofibromatous associated cases occur more in the central location, and non-hereditary cases more occur in the extremities? Find any difference there?
Ma'am, I haven't, I didn't notice any of those clinical difference in presentation.
Thank you. It was a nice.
Thank you, ma'am.
Dr. Neha, we can move on to the next.
Yes, ma'am. Yes, ma'am. Dr. Vibha, thank you so much for your presentation. Now moving on to our last presentation by Dr. Viral Jain. He is from Jhalawar Medical College. His topic is histopathological spectrum of orchidectomy specimen at Jhalawar Medical College, a retrospective study. Dr. Viral, have you? Yes, we can see you.
আগেরটাই তো সরছে।
Dr. Vibha, you have to stop sharing.
Dr. Vibha, please stop sharing. Yeah.
Yes.
Is visible?
Yeah, you are visible and audible.
Here one more paper, no?
Ma'am, this is the last one, ma'am.
Last one? Okay.
Yes, ma'am.
Thank you.
Dr. Viral, yeah, you may proceed.
Good evening, everyone. Myself, Dr. Viral Jain, PG resident from Jhalawad Medical College, presenting paper on histopathological spectrum of orchidectomy specimens at Jhalawad Medical College, a retrospective study. And overview to the study. Testes are affected by a varying range of non-neoplastic and neoplastic lesions. However, non-neoplastic lesions are much more common in occurrence than neoplastic lesions. Epidemiology of various non-neoplastic and neoplastic lesions in testes varies widely in different geographical boundaries. Incidence of undescended testes or cryptorchidism is calculated approximately 1 to 2% in 3 to 12 months of age worldwide. Similarly, neoplastic lesions such as germ cell tumor most commonly affect 15 to 45 years of age group. Out of all malignant tumors occurring in males, testicular malignancy constitute only 1 to 2% in its total. Our study will focus on histopathological spectrum of different testicular lesions, also to determine various incidence rate of non-neoplastic, neoplastic, malignant lesions, as well as age incidence in orchidectomy specimens. Our aim and objective for the study, first to analyze histopathological spectrum of testicular lesions, second is to determine the incidence of non-neoplastic and neoplastic lesions of orchidectomy specimen, third is to determine the age incidence of different testicular lesions. Material methods for study. All the orchidectomy specimen after excluding criteria received in Department of Pathology. Specimens will be fixed in 10% formalin. After gross examination, tissue will be processed in automated tissue processor with paraffin embedding and sectioning, and staining will be with hematoxylin and eosin stains. Various lesions will be histopathologically classified and studied according to WHO classification. Inclusion criteria for this study, it includes unilateral simple orchidectomy specimens, radical orchidectomy specimens, and bilateral orchidectomy specimens. It excludes small testicular biopsies received for infertility examination. Study will be done over a period of 3.5 years from January 2018 to January 2020, June 2021. In this period, we have taken 82 samples in consideration. These are the few photomicrographs for testicular atrophy, showing small tubules with thickened basement membrane and reduced number of germ cells with interstitial fibrosis. Leydig cell hyperplasia is seen, which are consistent with testicular atrophy. Now the photomicrograph for seminoma. It's in this section shows diffuse proliferation of large uniform tumor cells separated into nest with intense lymphocytic infiltration. The tumor cells are having central nucleus with prominent nucleoli and distinct cell membrane with clear cytoplasm. Maybe also have eosinophilic cytoplasm. These are the photomicrograph for adrenal carcinoma. In this section shows sheets separated by fibrous strands, which are infiltrated by lymphoplasmacytic cells, showing pleomorphic cells, vesicular and hyperchromatic nuclei with increased mitotic activity. There is an extensive area of necrosis also seen. Here are the observations. We have divided the lesions into normal testes, cryptorchid, torsion and infarction, gangrenous testes, atrophy, non-specific inflammatory conditions, abscess, seminoma, adrenal carcinoma, teratoma, and yolk cell tumor. We have divided different ages into different age groups. Group 1 is considered as 0 to 20 years of age. Group 2 is considered for 21 to 40 years of age. Group 3 is considered into 41 to 60 years of age. And group 4 is for above 60 years. In this retrospective study conducted out of 82 cases, 67 that is 81.71 of total were non-neoplastic, and 15, that is 18.29% were of neoplastic lesions. Among non-neoplastic lesions of testes, torsion, and infarction constitute major bulk of the study, that is 20 cases that constitute around 41.79% of non-neoplastic lesion. And out of neoplastic lesions, seminoma constitute major part, that is 7 cases out of 15 cases of neoplastic constitute around 46.67%. Neoplastic cases among age group of 21 to 40 years. Neoplastic cases among age group of 21 to 40 years are quite higher than other age group, whereas non-neoplastic cases are less among above 60 year of age group, while it's quite uniform among other age groups. This is a discussion. Testicular lesions exhibit broad histopathological spectrum. Non-neoplastic lesions are much more common than neoplastic lesions. Among non-neoplastic lesions, torsion and infarction is more common, while seminoma is much common among neoplastic one. Histopathological diagnosis of testicular lesion is the gold standard tool, as clinically it may mimic difference so that treatment and further management policy can be followed further. And these are my references. Thank you.
Thank you, Dr. Viral Jain.
Good presentation. Thank you.
Nice.
Thank you.
But you have done it in the future tense. Your methodology says that will be done later on. But it is already done. You are presenting it now. What was the usual indications of orchidectomy?
Ma'am, for usual indication, there is after doing the sonography, if there is reduced blood flow, then we have to done orchidectomy or the mass.
Accuracy was done before orchidectomy?
Yeah, yes, ma'am.
Thank you, Dr. Viral.
Yes, ma'am.
You can move from Neha now.
Ma'am, there is one. Ma'am, there is one question from delegate. Okay. Shall I read it out?
Yes,
ma'am.
Ma'am, this question that Dr. Viral, that there wasn't there any no mixed malignant germ cell tumor?
No, ma'am, I have not seen any case.
Oh. Ma'am, do you have any question, ma'am?
No, I think we can move.
No.
Okay, ma'am.
Thank you.
So,
thank you, ma'am.
Thank you, Dr. Viral Jain.
Thank you.
Thank you.
So
Thank you, Bhavna.
I thank all the organizers. And
Thank you.
Amita madam.
Bhavna,
madam.
Thank you.
Let us meet in the main hall. Let us meet in the
চল
main
এখন গল্প করতে যাব আমরা
let the other hall be finished.
কি করে যাব এটা লিভ করব
হ্যাঁ এটাকে লিভ করে যাও.
So now I request, thank you, Bhavna ma'am, for your wonderful cooperation and patient listening. I would give my heartfelt thanks to all the presenters for your beautiful and informative presentations. So now I request all of you to please join the main hall, and the link is given, and for prize and valedictory prize distribution and valedictory session. Thank you, all of you.
Well done, Neha.
Thank you, Neha. You
Thank
have
you,
done
ma'am.
a great job.
Thank you,
Nicely
ma'am.
managed.
Thank you.
Nicely
Thank you, ma'am.
managed. Yes.
So much. Thank you, ma'am. Your blessings, ma'am. Thank you, Bhavna ma'am. Thank you, Mamta ma'am. Thank you, Amita ma'am. So please let us join the main hall.